Thank you, Dr.
Thank you. No worries. Could we go to 541, please? Okay, thank you. So I'll be taking 541 to 550. I'm backing up like our able class rep said. So some of my explanations may not be as detailed as I would like to because I only had knew about this terminally. So 541 says a 44-year-old man with HIV infection presents to your office for evaluation of shortness of breath. He reports 2 months of progressive fatigue and dyspnea on exertion. He regularly takes a single pill regimen of ARVs consisting of a nucleoside reverse transcriptase inhibitor, a nucleotide reverse transcriptase inhibitor, an integrase strand transfer inhibitor, probably dolutegravir. His HIV viral load is undetectable and his CD4 count is 750 cells per millimeter cube. The normal is 500 to 1,500. TTE reveals a normal-sized ventricle and left ventricular ejection fraction of 55%. Which of the following statement is correct regarding HIV-associated cardiovascular disease? Now, this whole scenario is telling us that the patient has well-controlled disease. He has undetectable viral load. He's on recommended combination regimen. He's doing well and all of that, but he still has exertional dyspnea for 2 months. Some of the HIV cardiovascular diseases, I think yesterday, one of the questions, there was something about pericardial effusion. They could have HIV-associated cardiomyopathy, among other conditions. But with the advent of heart, you know, the prevalence of some of these have been reducing, but still patients with HIV still have elevated atherosclerotic cardiovascular risk compared to the general population, even when the disease is well controlled. So let's go through the option. It says A, the normal ejection fraction of, oh, by the way, we're looking for the true answer. It says which of the following statements is true regarding HIV-associated cardiovascular disease. So A, the normal ejection fraction excludes the presence of HIV-associated cardiovascular disease. This is false. As we know, we could have normal ejection fraction and still have a myriad of cardiovascular diseases. And LVEF is not the best measure of early subtle cardiovascular injury or cardiovascular disease. If we remember our global longitudinal strain on echo, we could have reduced GLS with normal LVEF in patients with a variety of conditions. So this is false. B, adjusting the patient's regimen to include a protease inhibitor would minimize his long-term risk of HIV-associated cardiovascular disease. This is also false. We may recall that protease inhibitors are notorious for causing dyslipidemia, which will accelerate atherosclerotic cardiovascular disease, and they're not even first line. So this patient has well-controlled disease, undetectable viral load, normal CD4 count. He has no reason to be changed to second line, which the protease inhibitors are generally reserved for. So this is also false. C, diastolic dysfunction may ensue even in patients with well-controlled HIV. So this is actually true. They can have subtle systolic and diastolic dysfunction, even in the presence of normal left ventricular ejection fraction, as we've mentioned. Then D, patients with well-controlled HIV develop, could we scroll up a bit? Thank you. Patients with well-controlled HIV develop atherosclerotic cardiovascular disease at rates similar to patients without HIV. This is false. They develop ASCVD at a much higher rate than the general population patients without HIV. And in this post-heart era, many HIV patients are dying of, CVDs, just like other people are, rather than infections or progression to heart. So that concludes 541. If anybody has something to add, please go ahead. Otherwise, we're moving.
Okay, let me just add something to option D, talking
Sure.
about the atherosclerotic cardiovascular disease in HIV patients compared to non-HIV. We know that the virus itself, its presence, confers some form of chronic inflammation, and the HIV patients are said to have premature atherosclerosis, which is directly related to the chronic vascular inflammation they have. And so we know that that will invariably lead to some endothelial dysfunction. So the acceleration in HIV patients is actually much faster, just to buttress further what you said.
Okay.
Thank you.
Thank you very much. And this sort of further highlights the intersection between infectious or communicable and non-communicable disease. So HIV is a good example. COVID too is a good example with the increased risk of thromboembolic phenomena, MIs, and all of that. So thank you. So 542. Which of the following statements regarding the cardiovascular consequences of Turner syndrome is correct? Turner syndrome is associated with a number of cardiovascular defects, I think most common of which is coarctation of the aorta. So let's go through the options. It says cardiovascular defects are seen in fewer than 5% of patients. It's a lot more than that. Patients with Turner syndrome have up to probably 20 to 50% of them have cardiovascular abnormalities. So it's not 5%. B, coarctation of the aorta is the most commonly associated congenital cardiovascular abnormality. This is actually true. Patients with Turner syndrome need to be kind of screened for coarctation of the aorta, actually. C, patients with Turner syndrome who developed aortic dissection demonstrate normal aortic elastic media. Part of the problems they have are, like on histopathological examinations, they have abnormalities of the elastic media of their vessels, and they can develop dissection independent of other aortic abnormalities. So even if they didn't have a coarctation, they can have aortic dissection. Even if they don't have an aneurysm, they could develop aortic dissection. So D, partial anomalous venous drainage occurs with similar frequency as in the general population. It occurs in a higher frequency than in the general population. So it's one of the cardiovascular defects that they have. Of course, Turner syndrome, we remember, is XO, so 45XO, one sex chromosome is missing. They are females, but they have one less X chromosome. They have delayed secondary sexual characteristics and all of that. And so coarctation is their main abnormality, as well as other aortic abnormalities like dissection. So again, welcoming comments. Okay, I can move on. They can also have bicuspid aortic valve in addition to the coarctation.
Sorry,
So
please, What's the true option there? Is it C?
It's B, ma.
B. All right, thank you.
Yes. That coarctation is their most common abnormality is B.
Okay, true. Thank you.
So question 543, a 20-year-old man with Duchenne muscular dystrophy presents for evaluation regarding cardiac involvement in his condition. Which of the following statements is true? Now, we might recall is an X-linked recessive disorder with abnormalities in the protein dystrophin. They can have musculoskeletal abnormalities as well as cardiac. And if we remember way back when we're learning, we're still learning, but causes of dominant R wave in lead V1, Duchenne muscular dystrophy, true posterior MI, RVH, RBB. So it's on that list. So let's go through and see. It says fewer than 25% of patients with Duchenne muscular dystrophy who are older than 18 years old develop a dilated cardiomyopathy. So by the time they're 18 years old, majority have developed evidence of dilated cardiac chambers, up to 90% actually. This 25% is for patients up to 6 years of age. So by 18 years of age, up to 90% of them have some evidence of dilated cardiomyopathy. So this is false, right? A is false. B, the ECG typically shows tall R waves with increased RS amplitude in V1 and deep narrow Q waves in the left precordial leads. This is true. Duchenne muscular dystrophy is a recognized cause of dominant R wave in V1. So the correct answer is B, but let's still go through the other options. C, there is a direct association between the presence of DCM and electrocardiographic abnormalities. There isn't really a direct association between ECG abnormalities and DCM. You could have one without typically, like you could have the dominant R waves without the DCM or the DCM, so there's no direct association. D, sinus bradycardia is the most common rhythm disturbance. Conversely, it's tachycardia. They can have persistent tachycardia and they can have tachyarrhythmias, both atrial and ventricular tachyarrhythmias. So any additions before we move?
I think they also cause AV blocks.
Okay. Okay. Somehow I think the arrhythmias maybe, it's so sinus tachycardia is the most common arrhythmia, but probably AV blocks are better. So 5, 4. Sir?
What's the answer, please?
The answer is B, that the ECG typically shows tall R waves.
Yeah, okay, thank you.
You're welcome. So 544.
Wait, let me just add one or two other things. Thank you very much, Ma. So like it has been rightly said, Duchenne muscular dystrophy is X-linked, X-linked recessive, but we also have Becker's muscular dystrophies, which also is X-linked recessive and is a disorder of the dystrophin gene. So when you are suspecting that the patients have Duchenne muscular dystrophy, the other clinical findings that you may find in them is pseudohypertrophy of the calf. They may have a waddling gait. They may have shortening of the Achilles tendon, hyporeflexia or areflexia. Those are the other things that you can find in such people. And doing a muscle biopsy will help in diagnosis and also dystrophin analysis and genetic analysis in this group of people. Thank you.
Thank you very much. 544. Okay, so it says a 34-year-old man is receiving doxorubicin chemotherapy for lymphoma. Which of the following statements regarding the risk of doxorubicin-induced cardiomyopathy is correct? Of course, we know of chemotherapeutic agents, the anthracyclines, so doxorubicin, daunorubicin, and idarubicin are known for their cardiotoxicity, and inducing doxorubicin-induced cardiomyopathy. So we'll try to find the true answer. That we're looking for one true answer among all of this. So A, it says previous mediastinal irradiation increases the long-term risk of valvular disease and coronary artery disease, but not cardiomyopathy. So the range of doxorubicin-induced cardiotoxicity can range from valvular, coronary artery disease, and the cardiomyopathy. And having had previous mediastinal irradiation, so like neoadjuvant radiotherapy, will increase the risk of all of them. So that is what makes A false. They said it decreases the risk of valvular disease, coronary artery disease, but not cardiomyopathy. It increases risk for all of them. B, age is not a risk factor for the development of cardiomyopathy. Actually, it is. Extremes of ages has increased risk. So the very young and the very old. Well, which this patient doesn't fall into, but still. So C, they said cardiomyopathy can develop with a total cumulative dose of less than 400 milligram per meter squared. So we'll come back to that. D says continuous infusion of anthracycline confers a greater risk of cardiotoxicity than intravenous bolus dosing. It appears to be the other way around. The bolus dosing tends to give more like injury than the lower dose intravenous infusion. So coming back to C, it appears that at many, how do I put it, at different dosing, so the effect of doxorubicin induced cardiomyopathy or cardiotoxicity is kind of dose dependent. So at different dosing, we have different cumulative risk of developing the side effects, the cardiac side effects. But even at doses less than 400, patients can develop the side effects. So generally, the target is that the cumulative dose shouldn't be more than 400 to 450. That's kind of the target to limit cardiotoxicity. But even at doses lower than this, cardiotoxicity could still develop, even though the risk is lower than if we keep going higher. So again, additions.
So C is the appropriate answer here.
Yes, C is the answer. So 545, it says a 63-year-old man with metastatic colon cancer is prescribed therapy targeting vascular endothelial growth factor. Which of the following statements is correct about the use of monoclonal antibody, vascular endothelial growth factor antagonist, bevacizumab? So this is one of the drugs used in metastatic colon cancer and lung cancer to target vascular endothelial growth factor and limit tumor growth and burden and all of that. What it does is it starves the tumors of blood supply. So, and eventually leading to the necrosis and whatnot. So, some of its side effects include hypertension, which is a recognized side effects. So let's go through the options. A says the left ventricular ejection fraction tends to increase with use of this drug. Let me go through the options and say the answers, since sometimes we don't hear. So B, hypotension is a common side effect. So even before I go any further, this is wrong, because hypertension is the common side effect. And it can be really very high in some instances. And it is pretty common, up to 20%. So up to 1 in 5 patients could develop hypertension. C, the risk of arterial but not venous thromboembolic events is increased. So this is true. They have increased risk of arterial thrombosis, but not venous thrombosis. So C is the true answer here. D, hemorrhagic pericardial effusion is associated with use of this agent. This is not a common side effect of the drug. So coming back to A is also wrong. There can be a progressive decline in left ventricular ejection fraction rather than increase. So C is the correct answer, that they have risk of arterial but not venous thromboembolism. So please, additions. And it's the side effects of this drug, this bevacizumab, is more common when patients have received anthracyclines or radiotherapy. So it's not monotherapy, it's used in adjunct with other methods, and the side effects are increased when these other methods like radiation and anthracyclines are used. So 546, a 2-year-old boy with Down syndrome and a heart murmur is brought to the pediatrician's office because of poor weight gain. So kind of failure to thrive, right? The most likely finding on cardiac auscultation is, so patients with congenital abnormalities that have cardiac involvement, some of the common presentations are failure to thrive, or poor weight gain and recurrent respiratory tract infections in childhood. Down syndrome is particularly associated with endocardial cushion defects. So we could have ASDs, VSDs, or partial or complete endocardial cushion defects. We could have affectation of the valves if it's extensive, and cardiovascular diseases on those that survive into adulthood. Cardiovascular disease is the most common cause of mortality. Now, the murmurs heard in Down syndrome depend on the extent of this endocardial cushion defect. We will go through the options, but for this, I think we might need to read out the answer because it explains in detail. If it's this extent, what type of murmur, if it's that. So let me go through the options. It says the most likely finding on cardiac auscultation is A, an early diastolic opening sound at the apex, followed by a diastolic rumbling murmur. This sounds like MS, right? Mitral stenosis, but let's move on. B, a mid-systolic murmur at the upper left sternal border and wide fixed splitting of S2. Okay, so if we have increased flow through the pulmonary arteries, it would tend to split the S2 further. So meaning the aortic will close and the gap before the pulmonary closes is wide. It's longer than usual. So C says a mid-systolic click followed by a late systolic murmur at the apex. Okay, this kind of, well, we'll read the answer. Let me go on. So D, a blowing diastolic murmur at the right upper sternal border, and E, a late peaking systolic ejection murmur heard best at the upper right sternal border with a diminished S2. So for this, I'll read out the answer with the class's permission. The correct answer is B, a mid-systolic murmur at the upper left sternal border and a wide fixed splitting of S2, because the most common abnormality is the partial endocardial cushion defect, which gives kind of the murmur similar to an ASD kind of, but with increased flow through the pulmonaries, given this wide fixed splitting of S2. But class rep, can I read the answer?
Yes, Chief, please go ahead. Thank you.
Okay. So can we scroll to the answer, please? Okay, thank you. So it says congenital heart lesions are the most common cause of morbidity and mortality in individuals with Down syndrome. So I said when they grow into adults, so it appears at all ages, possibly. The cardiac abnormalities are the most common cause of morbidity and mortality. The most frequent abnormalities are endocardial cushion defects, including partial or complete atrioventricular septal defects. So no septum between the atria and the ventricle, or defects in that whole area. The typical presentation includes a history of poor weight gain and frequent respiratory tract infections in the first year of life. Cardiac auscultation findings depend on the degree of atrial and ventricular septal communications and whether there is AV valve involvement. In patients with the more common partial endocardial cushion defect, the examination findings are similar to that of an ostium primum ASD. There is a prominent mid-systolic flow murmur because of increased flow in the pulmonary valve, followed by wide fixed splitting of S2. So this is what made C the answer. Sorry, B, the answer. A mid-diastolic murmur is also common owing to increased flow through the tricuspid valve. But the most common murmur from this partial endocardial cushion defect is a mid-systolic flow murmur with wide fixed splitting of S2, similar to ostium primum ASD. When a cleft mitral valve is part of the partial endocardial cushion defect, then a hollow systolic murmur at the apex is present that frequently radiates towards the sternum because the right atrium receives regurgitant flow in this condition. Okay. Okay, so it's kind of like an MR, but because the septum is missing, there's endocardial cushion defect, part of the interatrial septum is missing, part of the interventricular septum is missing, and then part of the mitral valve it's cleft. Then as the blood is regurgitating back into the left atrium, some of it will also enter into the right atrium. So that is why the murmur radiates towards the sternum rather than the usual towards the apex, towards the axilla that we find in an usual MR murmur. When interventricular communication exists as part of the defect, a hollow systolic murmur is usually present at the mid to lower left sternal border. A mid-systolic click followed by a late systolic murmur at the apex is the auscultatory finding of mitral stenosis. Okay, sorry, mitral. So a mid-systolic click followed by a late systolic murmur at the apex describes the auscultatory findings of mitral valve prolapse. Mitral valve prolapse occurs more frequently in patients with Down syndrome than in typical individuals, but it generally does not become evident until later in life. So this child was 2 years old. So it's not the usual age of presentation for mitral valve prolapse in Down syndrome, even though it is still not as common as the endocardial cushion defects. So choice A describes rheumatic mitral stenosis. Choice D is the murmur of aortic regurgitation, and choice E represents aortic stenosis. These entities do not occur at an increased frequency in patients with Down syndrome. So meaning we could have a question like the following are common cardiac lesions in Down syndrome: partial endocardial cushion defect, cleft mitral valve, these are true, but mitral aortic stenosis, aortic regurgitation are not found with increased frequency in Down syndrome, mitral stenosis. Thank you.
Thank you so much. Please, any additional comments or contribution from the class? Okay. So please, let's continue.
Okay. So 547. Okay. So a 35-year-old man presents with complaints of exertional dyspnea. His medical history is significant for chest radiation therapy as a teenager for treatment for a hematologic malignancy. Regarding cardiovascular effects of radiation therapy, which of the following statements is true? Now, patients that receive radiotherapy can develop cardiovascular side effects, but they usually take time to develop, usually a decade at least. And constructive pericarditis is pretty one of the common ones. And it, like we said, it might take time to develop. But they could also have coronary artery disease, conduction system abnormalities, valvular heart disease. So the radiation can affect all all layers, or restrictive cardiomyopathy due to fibrosis occurring later on. So we can have pericardial, myocardial, endocardial disease, conduction system disease. But with this exertional dyspnea, it sounds like it's likely pericardial. Let's go through. So it says most cardiovascular complications develop within 5 years of radiation exposure. They usually take about 10 to 20 years, so at least a decade. So this is false. We are looking for one true answer. Constrictive pericarditis is typically an acute reaction to radiation therapy. It's not acute, it's usually chronic. So it's a long-term side effect. C, the conduction system is typically spared from adverse effects of radiation. We just said that the conduction system can be affected as well. D, dilated cardiomyopathy is the most common manifestation of mediastinal radiation therapy. So should they develop cardiomyopathy, it's going to be a restrictive type, usually not dilated. So this is also false. So E, cancer survivors who received head and neck radiation are at heightened risk of stroke. So E is the true answer. Cancer survivors who receive head and neck radiation are at heightened risk of stroke. Just like the coronary arteries can be, radiation can cause coronary artery disease. We could also have like stenosis and endothelial dysfunction and all of that happening in the carotids upwards due to head and neck radiotherapy. So any additions, please?
Please continue, ma'am.
Okay, so 548. So it says, which of the following statements is correct regarding familial forms of dilated cardiomyopathy? So we're talking about DCM, but particularly the familial forms. So A, familial forms account for less than 5% of cases of DCM. This is not true. They account for a larger percentage. I think up to a quarter, or like 25-30% thereabouts are familial. So B, most inherited forms fit an autosomal recessive pattern. This is also false. Most of the inherited forms are autosomal dominant, but there are some fewer autosomal recessive type mutations, and even some X-linked, fashion of inheritance for some mutations. But the most common ones are autosomal dominant. So most inherited forms are autosomal dominant rather than recessive. C, familial DCM commonly results from mutations in genes that encode sarcolemmal surface receptors. This is also not true. Most of the proteins affected, the mutations are for proteins that code cytoskeletal or contractile proteins, like the ones mentioned from yesterday's presentation on the heart as a pump. So the contractile proteins sometimes mitochondrial mutations, but these are less common, and cytoskeletal. So mainly contractile and cytoskeletal, with fewer being nuclear membrane proteins. So this is also false. D, in symptomatic patients, histologic examination of the heart typically demonstrate extensive areas of interstitial and perivascular fibrosis. So this is true. Generally, histologic examination of DCM would reveal extensive areas of interstitial and perivascular fibrosis, especially in the left ventricle. And this is part of what comes out when we do cardiac MRI to show late gadolinium enhancement, is this fibrosis that has occurred, interstitial and perivascular fibrosis. So D is the true answer. E says familial cardiomyopathy can be readily identified as the cause of DCM by specific immunologic markers. At present, they aren't exactly immunological markers, rather genetic markers. So genetic studies are needed to identify those genes rather than immunologic markers. So the correct answer here is D, that in patients with symptomatic familial DCM, when we do histological examination, we find extensive areas of interstitial and perivascular fibrosis. And should we do CMR, we would probably see areas of late gadolinium enhancement. So, additions, comments?
Please, sorry, what's the reason for C, please?
B, they said that the genes encode sarcolemmal surface receptors, while mainly which that makes it false. The genes affected in DCM are usually cytoskeletal, contractile proteins, or some nuclear surface receptors, not sarcolemmal surface receptors.
Okay.
So 549 going. All right. Could we scroll? Thank you. Okay, so 549 says 65-year-old man with a history of chest radiotherapy for lymphoma presents with worsening exertional dyspnea. On physical examination, the heart rate is 120 beats per minute, so he's tachycardic. Blood pressure 90 or 55 millimeters of mercury, borderline, tending towards hypotension, with pulses paradoxes of 15 millimeters of mercury, so significant. The jugular venous pressure is 10 centimeters of water, so raised JVP with prominent X descent. He is found by echocardiography to have a large pericardial effusion, which is drained by pericardiocentesis in the cardiac catheterization lab. After the procedure, the intrapericardial pressure normalizes, but the initially elevated right atrial pressure fails to decline and displays a prominent Y descent. This scenario is most consistent with. So this patient had chest radiotherapy, developed pericardial disease with a massive pericardial effusion, probably even tamponade at presentation, which was drained. And the intrapericardial pressure has dropped, but he still has elevated right atrial pressure. So meaning there's still some, constriction or restriction. So let's see. They said this scenario, so his final scenario is most consistent with A, they said persistence of pericardial tamponade. No. So if the pericardial tamponade was still there, then the intrapericardial pressure would still have been high. But after drainage, the intrapericardial pressure had normalized. Cor pulmonale, no, we didn't have any history of long-standing lung disease. C, effusive constrictive pericarditis. This is actually the answer. So it's effusive constrictive pericarditis. We've drained the effusion, but the constriction is still there. So C is the correct answer. D, restrictive cardiomyopathy. No, this is not correct. Then E, uremic pericarditis, which we were not told anything about his renal function or urea or creatinine levels. So the correct answer is C, effusive constrictive pericarditis. Do we want to read the answer, or are we okay with this explanation?
Well, we can just
Let's
read the
read
answer.
the answer.
We can just read the answer.
Ma? Someone
Let's
was
read it.
speaking as well. Okay. So C, the answer is C, effusive constrictive pericarditis. So it
Yeah.
says the clinical scenario. Okay.
Out.
That's
No, you can read it. You can read.
okay. I'm trying to open it to save time as well. So, but still get there in case people want to follow. So the clinical scenario most consistent with effusive constrictive pericarditis, which indicates the simultaneous presence of a hemodynamically significant pericardial effusion and visceral pericardial constriction. So there's constriction of the visceral pericardium, then you had hemodynamically significant pericardial effusion. This pathophysiology leads to hemodynamic hallmark of the condition, which is, so the hemodynamic hallmark of effusive constrictive pericarditis is continued elevation of right atrial pressure following aspiration of pericardial fluid, despite return of intrapericardial pressure to normal. So this hemodynamic hallmark is, I think, exclusive to effusive constrictive pericarditis. So someone had effusion, it gets drained, the intrapericardial pressure returns to normal, but right atrial pressure remains elevated. The causes of this entity are the same as those for chronic constrictive pericarditis. The most common include idiopathic or post-viral pericarditis, neoplastic infiltration of the pericardium, mediastinal radiation therapy, and tuberculosis. The physiological findings on initial presentation, so the findings he came with, the initial part of the scenario, are most consistent with cardiac tamponade, including pulsus paradoxus, raised JVP, and prominent X descent. The diagnosis of effusive constrictive pericarditis is made at cardiac catheterization. So it's a cardiac cath diagnosis with careful hemodynamic monitoring of intrapericardial and right atrial pressure before and after pericardiocentesis. So like we said, the scenario has to be someone had pericardial effusion, it gets drained. So they had pericardial effusion, they get cardiac catheterization before the drainage, showing raised intrapericardial and right atrial pressure. Then after drainage, the intrapericardial pressure falls back to baseline, which is approximately 0 millimeters of mercury after pericardiocentesis. But the intracardiac pressures, especially the right atrial pressure, fails to go back down to normal. So rather hemodynamic findings convert to a form more consistent with constrictive pericarditis. So they also have prominent Y descent with right atrial pressure tracing and that dip and plateau square root sign that we saw some days back in the RV pressure tracing. So similar to constrictive pericarditis. As might be expected from the pathophysiology, pericardiocentesis provides only partial and transient symptomatic relief. Definitive therapy for this condition requires total pericardiectomy. So I hope that has shed more light. So for the scenarios, we would typically, like I said, find right heart cath explanations to make this diagnosis of effusive constrictive pericarditis.
Excellent. Thank you so much, Chief Rookie, for billing us out. We
No
are really
worries.
very grateful. We've done
What?
550 before.
Okay, we've done 550. Okay, that's
Yes.
okay. So that means that ends my impromptu section, and I
Yeah,
hope that has been useful.
it has been. It has been. It's better than not doing it at all. Thank you so much. Dr. Alagbe, Dr. Maduka is okay. Ready to assist us with your part, ma.
Okay, I think
Thank
it's
you.
51.
Yes, yes. Let me check. It's 651 to 660. Thank you.
Okay, 651. A 60-year-old woman with history of hypertension and DM is admitted to the hospital because of an acute severe headache, nausea, and vomiting. Physical exam demonstrates a BP of 180/90 mm of mercury, normal JVP, bibasilar rates, no cardiac gallops, no OMO, and no focal neurologic signs. Troponin I is elevated at 0.62. Normal is less than 0.1. CT of the brain demonstrates acute subarachnoid hemorrhage. The patient's ECG is shown in figure 5.1. Which of the following statements is true? Okay, this is the ECG. So from the question already, the patient had the CT showed that the patient had subarachnoid hemorrhage. Then no significant cardiac finding apart from the BP that is elevated. Then troponin I, which is a biomarker, also slightly elevated. So looking at this ECG, we can see T wave inversion in lead 1 and AVL. Then when we look at precordial leads, we can see deep symmetrical T wave inversion from V2 to V5. Then if we look at V3, sorry, okay, I'm the one. So if we look at V3, there's slight ST depression, is more in V4 and a little bit more in V5. So this finding is consistent with subarachnoid hemorrhage, just as they told us from the CT. Subarachnoid hemorrhage is a strong differential of deep symmetrical T waves in precordial leads, just like apical HOCM. So it's a strong differential. So from here, they've already told us the diagnosis. So it's just to look for the ECG features. And apart from the deep symmetrical wave, they can also give ST depression and even sometimes ST elevation. So we can see ST depression here in about 3 precordial leads. So going to the option, a ruptured coronary plaque with partially occlusive thrombus is likely present. This is false. QT interprolongation is uncommon in this setting. Okay, this is also false. Sorry, that's another ECG finding. So we can have deep symmetrical T wave inversion, ST depression, slight ST elevation, and prolongation of QT interval. It can also be seen in them. So then option C, all of the cardiac abnormalities can be attributed to autonomic dysfunction in the setting of acute brain injury. This is actually the true option. It is said that with any bleed or any form of injury to the brain, they tend to have autonomic dysfunction. So this is responsible for most of the findings that is both on ECG and physically. Hello?
Yes. We have many cardiologists in the house there. We are trying to filter out
Pardon?
the background. I said we have many cardiologists in the
Sorry, my children are awake. That's why
I
they are making
know.
so much noise.
We are trying to
Okay, I'm
filter.
coming, please.
Okay, let's give you some minutes. Thank you.
Okay, sorry, please, I'm back.
Thank you. Welcome back.
Yeah. Yes, thank you. So option D, beta blockers are not effective at controlling ventricular tachycardia and fibrillation in this situation. This is also false. It has been shown that beta blocker is effective in the autonomic dysregulation that they may have that could lead to VTAG and AFib. Then increased magnitude of electrocardiographic abnormalities in such a patient is predictive of a worse outcome. This is also false. It's said that the electrocardiographic abnormality is not predictive of outcome. Any comments? Okay. 652. A 68-year-old man with a history of MI is scheduled for elective hernia repair. Which of the following statements regarding perioperative medication use in coronary disease patients undergoing non-cardiac surgery is true? A. Cardiac adverse event rates are reduced when high-dose beta blocker therapy is initiated immediately before surgery. This is false. It said that patients that are chronically on beta blockers can continue taking the beta blockers even pre and post surgery. So starting it just before surgery to reduce cardiac events has not been shown to be beneficial. Then nitrates decrease intraoperative myocardial ischemia and reduce rate of adverse cardiac outcomes. This is also false. They said nitrates have not been shown to decrease any intraoperative myocardial ischemia in patients on non-cardiac surgery that have background coronary artery disease. Then most cardiac medications should be discontinued 2 to 3 days before surgery and resume as soon as the patient can tolerate oral intake. This is also false. They said patients that have been taking cardiac medications chronically can keep taking their drug till the day of surgery, and immediately after the surgery, they can commence their drugs back. So they don't discontinue 2 to 3 days before the surgery. They just avoid it on the day of surgery, and after the surgery, go back to it. D. Statin therapy has been associated with reduced perioperative cardiovascular event rate in high-risk patients. This is actually the true option. It has been shown that patients that have coronary artery disease now undergoing non-cardiac surgery, statins tend to protect them from any adverse cardiovascular events that may occur around the surgery. So this is the true option. Any comments? (653).
Okay.
Which of the following statements regarding alteration in the cardiovascular function with aging is not correct? Okay. With aging, there's an endothelial dysfunction which means there's decreased production of nitric oxide. There's also increase in arterial resistance. That's arterial peripheral resistance. So this tends to lead to left ventricular hypertrophy because the heart will try to hypertrophy to gather muscle to pump. So they said myocardial cells don't increase in numbers, instead they will increase in size. So instead of them to undergo hyperplasia in order to overcome that resistance, they don't have that ability, so they increase in size. Then also they said with aging, even though the contractile ability of the myocardial fibers reduce, but that doesn't alter their stroke volume, their cardiac output. And then in elderly people, the normal physiological response to stress, to exercise, does not occur in them. So when someone is exercising, or the younger age group, that heart rate that we see, an increase in blood pressure, is actually minimal with the older age group. So now to the options. A, endothelial production of nitric oxide decreases with age. This is true. We are looking for the not correct option, so this is true. Left ventricular myocardial cells typically develop moderate hypertrophy. This is true. I said it. They cannot increase in number, but they can increase size. So this is true. Then option C is there is a decline in stroke volume due to a decrease in peak contractile force. This is false, so this is the true option we're looking for. I said despite aging, they don't have decline in stroke volume and cardiac outputs. So there's no decline in stroke volume. So this is the false option. Then D, heart rate during exercise increases less in older compared with younger individuals. So said earlier that the response to exercise in the older age group is less compared to the younger one. So this is true. Then the resting ejection fraction tends to remain constant with age in the absence of cardiac disease. This is also true. So with aging, no change in ejection fraction, stroke volume, and cardiac output in the absence of cardiac disease. So the false option here is there's decline in stroke volume due to a decrease in peak contractile force. Any comments? (654). A 58-year-old man with type 2 DM develops fever and tears at the sternal wound site 12 days after coronary artery bypass graft surgery. Which of the following has not been associated with the development of deep sternal wound infection after cardiac surgery? So this is a case of a deep sternal wound infection following CABG. So deep sternal wound infection is actually occur like 2 weeks, like 5 to 2 weeks after a cardiac surgery. And they present with fever, leukocytosis, erythema at the site of surgery, and they may also have bacteremia. So usually 2 weeks. So this happened 12 days after the surgery. And there are some risk factors that predisposes them to having this. So they include prolonged cardiopulmonary bypass time, the use of both internal mammillary arteries as bypass vessels, DM, then perioperative atrial fibrillation, increasing age, and obesity. And it has been said that obesity is a very strong risk factor for wound dehiscence. So coming back to the question, so I've listed the risk factors. So we're looking for one that is not true. So prolonged cardiopulmonary bypass time is true. So the longer the cardiopulmonary bypass, the higher the risk of sternal wound infection. The use of both internal mammillary arteries as bypass vessels, this is also true. DM, this is also true. History of cigarette smoking prior to surgery, this is false. It's not part of the risk factors. Then pre-operative atrial fibrillation is also true. So the false option here is history of cigarette smoking prior to surgery. Any comments? Okay. 655. A 27-year-old woman undergoes right heart catheterization for assessment of suspected pulmonary atrial hypertension. The mean pulmonary atrial pressure is 44 millimeters of mercury, and the pulmonary capillary wedge pressure is 11 millimeters of mercury. Infusion of epoprostenol reduces the mean arterial pulmonary pressure to 31 millimeters of mercury with no significant change in cardiac output and pulmonary capillary wedge pressure. Which of the following statements is not correct? Okay, these patients underwent cardiac catheterization and the mean PAP was 44. Then the capillary wedge pressure 11. So this shows that the patient actually has a pre-capillary pulmonary hypertension because the pulmonary capillary wedge pressure is not up to 15. You know, we use the cutoff of 15 to differentiate pre-capillary and post-capillary. So anything less than 15 is pre-capillary. Anything greater than 15 is post-capillary because the pulmonary capillary wedge pressure is reflective of the left atrial pressure. So this is a pre-capillary pulmonary hypertension. Then IV epoprostenol was infused. This is the vasoreactivity test. So after infusion of the IV epoprostenol, the mean PAP came down to 31. The mean PAP came down to 31 with no significant change in cardiac output or pulmonary capillary wedge pressure. A positive vasoreactivity testing is actually after the infusion of the epoprostenol or inhaled nitric oxide or IV adenosine or inhaled iloprost. If there's change of greater than 10 millimeter mercury in the mean PAP, that's it decreases with 10 or more, it's a positive test, or it comes to an absolute value of less than 40 millimeters of mercury, and there should be no significant change in cardiac output or pulmonary capillary wedge pressure. That's actually a positive one. So looking at this question, this patient had a positive vasoreactivity testing. So they're asking us if the following statement is not correct. Both intravenous adenosine and inhaled nitric oxide are alternative useful agents to assess vasoreactivity. This is true, so it's not what we are looking for, because I said we use 2 IVs and 2 inhaled. The IVs are IV ipoprostenol and IV adenosine, then inhaled nitric oxide and inhaled iloprost. So this is true. The observed drop in mean PAP is predictive of a favorable response to oral calcium channel blocker. This is also a true statement, because patients that have positive vasoreactivity will benefit from high dose calcium channel blocker. Then the failure of systemic blood pressure to decline suggests that the vasodilator challenge was ineffective. This is actually false. Normally, during the vasoreactivity testing, we said it's positive if there's no change in cardiac output. So for the BP to decline, that means there will be a change, most likely, to the cardiac output. But because part of the definition is that there should be no change, so it's likely not to touch the BP. So that's why this is false. So saying that the change is ineffective is actually false, because the BP did not decline. Then D, very high dose of chronic calcium channel blocker therapy will likely be necessary to realize full clinical benefit. This is true. High dose of calcium channel blocker. Then E, the rise in pulmonary capillary wedge pressure in response to vasodilator therapy will be of concern for impending left ventricular failure. This is a true statement. After the vasoreactivity testing, a positive one is that there should be no change. But if there's a change to pulmonary capillary wedge pressure, that shows that the problem is actually post-capillary pulmonary hypertension. So it's telling us that something is happening in the left, or there's a pulmonary venous hypertension. So the correct answer here is C. Any comments?
Thank you very much. Is there any explanation of this option D? This high doses of chronic calcium channel.
That's the treatment. If patients have, after the vasoreactivity testing, if they have a positive result, the treatment is that they will benefit from a high dose calcium channel blocker given for a long time. So that's what it's just saying, that very high doses of chronic calcium channel blocker therapy will likely be necessary to realize full clinical benefits.
Okay, thank you. But what is high dose now in this case?
They said in people with, I think they give them as high as, they give them amlodipine as high as 20-30 milligram. I know this is only in pulmonary hypertension that you give amlodipine more than the normal 10 that we give. They give them as high as 20-30.
Thank you. Thank you.
You're welcome. 56. Which of the following intervention has been shown to reduce the incidence of contrast-induced AKI after coronary angiogram in patients with chronic renal insufficiency? So, contrast-induced AKI, now they said the new name is contrast-associated AKI, is actually a form of renal dysfunction that happens after administration of a contrast media. And so when they compare the baseline U and E, or the baseline creatinine, with the post-coronary angio creatinine, so if there is a 44 micromole per liter increase, or 20, I think 25%, I'm not too sure again, but I know the absolute value is 44. if there's a difference in the pre and post serum creatinine of 4 micromole or more, it suggests that the patient most likely has had contrast-induced AKI. So that is what this question is all about. So, and the risk factors are maybe background renal dysfunction, increasing age, DM, and other things. Then even the volume of the contrast media you used, you use more than 100 mils, the patient is at risk of having contrast-associated AKI. And then also, if you use hypertonic contrast media, it also predisposes them to contrast-associated AKI. So the option of 20% mannitol before angiography, this is false. We are looking for the intervention that will reduce the incidence. This is false. Then administration of atrial natriuretic peptide, this is also false. C, normal saline administration before and after angiography, this is the true option. So they said that patients with underlying chronic renal insufficiency, once they want to go for coronary angio, they should be properly hydrated before the procedure and after the procedure. Then option D, oral administration of N-acetylcysteine. This is actually controversial. Some people said after the rehydration that you can give the patient N-acetylcysteine, but this is actually controversial. But for this question, according to Braunwald, is false. Then low dose dopamine infusion, this is also false. So for treatment of contrast-associated AKI, you preload with fluid, and then after the procedure, you also give fluid and monitor the serum and E. Any comments? Okay, 6:57. A 42-year-old woman presents to her primary care physician with recent fatigue and weight gain. A laboratory evaluation reveals a markedly elevated thyroid-stimulating hormone level. Which of the following is not a common cardiac in patients with hypothyroidism? So option A, okay, sorry. As we know, hypothyroidism is a state in which the thyroid is hypoactive, and they have markedly elevated TSH with low level of free T3 and T4. They also have some cardiac manifestations, like they have hypertension. And the reason for the hypertension is actually due to increased peripheral resistance. They say people that have decreased thyroid hormones tend to have increased sympathetic tone. So this predisposes them to having hypertension. Then they may also have relative bradycardia. Then because of increased vascular permeability in them, they will have transudation of fluid into the pericardial space, so giving them pericardial effusion. And then because there's relative bradycardia, it can affect the cardiac output. So they'll have a decreased cardiac output. And then they normally will have prolonged QT interval on ECG. And this is due to the slow rates of myocardial depolarization as a result of the absence of the thyroid hormones. So the option now, which of the following is not a common cardiac finding in patients with hypothyroidism? So hypotension, this is true. I said hypertension. So option A is true. That's what we're looking for. Then option B, increased heart rates. This is true, so it's false. Pericardial effusion is true, so that's not what we're looking for. Decreased cardiac output is true, not what we're looking for. Prolonged QT interval is true, so that's not what we're looking for. So option A is the false option here. Any comment?
Thank you, Chief.
So-
I think the kind of, just like for the same reason you gave of increased sympathetic tone, the hypertension that they tend to have is more of a diastolic.
Yes,
Diastolic,
yes,
yeah.
yes,
Thank you.
because their afterload is increased. Okay, 658. 28-year-old woman with Marfan syndrome presents for an office visit. Her echo shows mitral valve prolapse, an aortic root diameter of 4.5 centimeters, and a mild aortic regurgitation. Which of the following statements regarding cardiovascular disease in patients with Marfan is not correct? We've said a lot about Marfan. Let me just go straight to the question. Some 60% to 80% of patients with Marfan syndrome have mitral valve prolapse on echo. This is true. He said about 60 to 80%, about 2/3 of them have mitral valve prolapse on echo. Then the development of aortic regurgitation correlates with aortic root diameter. This is also true because they said the wider the diameter, the more apart the cups of the valve, then the more the regurgitation. Then option C, patients with Marfan syndrome should be considered for elective aortic root replacement once the aortic root diameter exceeds 5.5. This is actually false. Several studies have revealed that once the aortic diameter is around 4.5 to 5, they should have an elective root diameter, not 5.5. So 5.5 is higher. So anything from 4.5 to 5, they should have a replacement done. Then beta blocker should be administered to all patients with Marfan syndrome unless a contraindication exists. So this is true. We know that in patients with Marfan syndrome, because of the aortic aneurysm they have, we want to reduce the shear stress, the aortic shear stress. So, and that's one of the things that the beta blocker does. By it reduces the stress on the wall to prevent further complications. So, and also they said angiotensin receptor blocker too has effects on the wall of the aneurysm. So they can be used separately or they can be used in combination. So this is true. Then E, the risk of aortic dissection during pregnancy in patients with Marfan syndrome is increased if the diameter of the aortic root exceeds 4 centimeters. Yes, this is also true. It said pregnancy tends to predispose patients with aortic aneurysm to aortic dissection, especially when the diameter is 4 and above. So the correct option here is C. That's the false option. Any comments? $6.59. A 54-year-old was admitted to the hospital because of acute pulmonary embolism. IV administration of heparin was begun. On admission, the platelet count was 223,000. 6 days later, it fell to 36,000, although the patient remained asymptomatic without overt bleeding. Which of the following statements regarding this patient's condition is true? So from this scenario, we can see that the patient had PE and the patient was given heparin. Then after 6 days, the heparin, the value went down, but the patient is asymptomatic. So this patient developed thrombocytopenia after heparin administration. So likely this patient has heparin-induced thrombocytopenia. So they are asking us correct statements regarding the patient. So 1, lower molecular weight heparin can be safely substituted for IV unfractionated heparin. This is false. In heat, unfractionated heparin has been implicated, but also they found out that even when you administer low molecular heparin, they tend to cross-react with the antibodies that were developed from the unfractionated heparin, and then they'll still give the same reaction. So in them, you avoid low molecular weight heparin and you avoid fractionated heparin. So you prefer things like valirudin or fondaparinux. That's what you give. So option B, a direct thrombin inhibitor such as bivalirudin should be substituted for heparin. This is true. C, intravenous heparin should be continued because the low platelet count represents laboratory artifacts without clinical significance. This is false. You actually have the thrombocytopenia. It's not an artifact, and therefore you shouldn't continue the intravenous heparin because they will keep forming antibodies and it will keep destroying the platelets. The antibody antigen complex will keep destroying the platelets. Then D, antibodies directed against platelet glycoprotein 2B 3A receptor participate in this disorder. This is false. The antibodies are directed against the heparin platelet factor 4. Option E, this is a transient reaction to heparin and does not preclude future heparin treatment for this patient. This is also false because once they develop the antibodies, future heparin treatment, they still mount the reaction. Any comments? Okay. The last question, 660. A 51-year-old woman presents to discuss anticoagulation options for AFib. Her history is notable for rheumatic mitral stenosis, which led to mitral valve replacement with a St. Jude's mechanical prosthesis 6 years ago. She had AFib prior to cardiac surgery, and it has persisted thereafter. She has been maintained successfully on warfarin anticoagulation, but she wishes to free herself of the required frequent testing of prothrombin time and dose adjustment. She asks if one of the newer anticoagulants will be an option for her. She has normal renal function. Which of the agents below will be appropriate for these patients? Which of the agents below will be appropriate for this patient? So the patient has rheumatic mitral stenosis and she had the valve replacement and so she still has AFib. So according to guidelines, it's stated that patients that have AFib with mechanical valve or mitral stenosis should be on the preferred anticoagulant is warfarin. According to the realigned trial where they compared the efficacy of warfarin and dabigatran in people that have bileaflet valve, they found out that the people that received dabigatran had higher rates of bleeding and they even had thromboembolic phenomenon. So this study actually favored the use of warfarin. So this question now is asking us that the woman wants another option because she's tired of using warfarin because of the dosing and the dose adjustment. So they're asking us, what other alternative can we give her? Is it rivaroxaban or apixaban, dabigatran, or none of the above? So the answer is none of the above. She will only benefit from warfarin. Thank you. Any comments?
Let me add that a more other recent study that looked at rheumatic heart disease, atrial fibrillation, anticoagulation that compared warfarin with rivaroxaban, the Invictus trial, of which there were centers from Nigeria. It's also a multi-center study. I don't remember all of the countries, but I know there were centers from Nigeria because my center, AKTH, kind of was one of the centers. The results also came out in favor of warfarin in atrial fibrillation around rheumatic heart disease.
Yeah, it's true.
Support.
I don't hear you.
She's talking about the Invictus trial.
I was saying the recent Invictus trial that compared warfarin to rivaroxaban in patients with rheumatic heart disease and I think atrial fibrillation also found warfarin to be superior to rivaroxaban in this group of patients, and it had centers from Nigeria. I don't remember all of them, but I know that Aminu Kano Teaching Hospital was one of these centers. So even local data of African patients also support this finding that warfarin is better in rheumatic heart disease.
Dr. Adeyejo, I'm done. Hello? Hello?
Good evening, everybody. Am I the only person that does not hear anything? Okay, I hear you now. Okay, the next person should be able to start. But Alamba just finished. The next person should be able to start. She's just done with her own. So let me know that she's good and start.
Okay, I want to take 511 to, this is Dr. Brown. I want to take 511 to 520, which is my section.
If the person sharing can share the screen. Nothing I'm watching, so the message is on from my own end. The screen is off. Even sure can share the screen. What you can go.
Are you okay, Dr. Brown?
Okay, so thank you for sharing, Chief. So, let me read question 511. A 34-year-old man presents to the emergency department with pleuritic chest pain after a recent upper respiratory tract infection. The pain is positional, relieved by sitting up. Cardiac examination is notable for a 3-component friction rub. The ECG demonstrates diffuse ST segment elevation, segment depression in several leads. Which of the following statements about the evolution of this ECG in this condition is correct? Okay, so the clinical scenario painted here is that of a 34-year-old patient who has previous upper respiratory tract infection and now has pleuritic chest pain that is relieved by sitting up. Physical examination also reveals a friction rub. And then on the ECG, there is diffuse ST segment elevation with PRO segment depression. So I think the clinical scenario being painted here is that of an acute pericarditis. That's the condition here. So we'll go through the question. They say which of the following statements about the evolution of the ECG in this condition is correct? Say A, PRO segment deviation occurs in fewer than 25% of patients with this condition. B, initial ST segment elevation is usually most prominent with AVRO. The ratio of the height of ST segment elevation to the height of the T wave in this condition is typically less than 0.25 in the D6. T wave inversion is expected to occur within days while the ST segment is still elevated. T wave inversion may persist for months after the acute presentation. So I just want to talk about the evolution of the ECG briefly in pericarditis. So the evolution of the ECG, there are actually 4 stages of ST segment and T wave changes in acute pericarditis. So for stage 1, what you have is a concave ST segment elevation, and this occurs in all leads except AVRO and B1. So this B option is wrong, where it is said that initial ST segment elevation is usually most prominent in AVRO. ST elevation occurs in stage 1 and in all leads except leads AVRO and B1. So also in stage 1, we also have upright T waves. Apart from the ST segment elevation, there are also upright T waves. And then you also have a PRO segment depression which occurs in approximately 80% of patients. So that also makes the A segment wrong. The A segment says PRO segment deviation occurs in fewer than 0.5% of patients with this condition. It actually occurs in approximately 80% of patients, which is stage 1 of the ECG changes. What you have in stage 2 of the ECG evolution in patients with acute pericarditis, you now have a return in stage 2. So stage 1, ST segment elevation, upright T waves, PRO segment depression. In stage 2, you now have a return of the ST segment to baseline, then you have a flattening of the T waves. That's what you have in stage 2. Then in stage 3, you now have an inversion of the T waves. That's what you have in stage 3 of the evolution of the ECG, which occurs in some patients, but not all patients. Then stage 4, what you now have in stage 4 is this T wave inversion. You now have reversion of the T wave to normal in those who had T wave inversion in stage 3. That's what you have. Well, that's what you see in stage 4. And what happens is that most times this stage 4 may not even occur for weeks or months after the acute event. Stage 4 takes some time. So these are the 4 stages of ECG evolution in acute pericarditis. And it occurs in approximately 50% of all patients with acute pericarditis. That's what you find. So looking at the options again, A is wrong. I've said that this PRO depression occurs in about 80% of patients. D is also wrong. They say an initial ST segment elevation is usually most prominent in AVRO. ST segment elevation occurs in all leads except B1 and AVRO. So that's wrong. Then option C, the ratio of the height of ST segment elevation to the height of the T wave in this condition is typically less than 0.25 in the B6. This is another wrong option. In fact, the way to differentiate the ECG in pericarditis from what you see in early repolarization, where you also have ST segment elevation, is that the ST segment to T wave ratio is greater than 0.25 in lead B6 for those with acute pericarditis. While for those with changes of early repolarization, the ST segment T wave ratio is less than 0.25. So that's for early repolarization. So this C, where it is said that it's typically less than 0.25 in lead B6, it is wrong. It is greater than. That's what suggests pericarditis. So C is also wrong. Then D, T wave inversion is expected to occur within days, while the ST segment is still elevated. So this is a wrong option. This is a wrong option. If we go through the stages again of the ECG evolution, we can see that T wave inversion occurs in stage 2 after the ST segment has returned to baseline. So the T wave inversion cannot occur when the ST segment is still elevated. So this is a wrong option. T wave inversion occurs when ST segment has returned to baseline. So D is also wrong. So the correct answer for this option is E. T wave inversion may persist for months after the acute presentation. I mentioned when I was going through the stages that stage 4 may not occur for weeks or months after the acute event. So E is the correct option. Thank you. I don't think there are any other contributions.
Yes, please. Can you go through that stages again, please?
Okay. There are 4 stages of ST segment and T wave evolution in acute pericarditis. So what you have in stage 1 are basically 3 things: ST segment elevation, upright T waves, and then PRO segment depression. These are the changes which occur in stage 1: ST segment elevation, upright T waves, and PRO segment depression. Then what to note about the ST segment elevation is that it occurs in all leads except leads AVRO and B1. That's why option B is wrong, where it was said that initial ST segment elevation is usually most prominent in lead AVRO. lead AVRO and V1 are the leads where ST segment elevation does not occur. All other leads, there's ST segment elevation. So that's stage 1. Then what you now have in stage 2 is that you have a return of the elevated ST segment to baseline. In stage 2 of the ST segment and T wave evolution, there's a return of the ST segment to baseline. And there's also the T waves that were upright in stage 1 become flattened in stage 2. That's stage 2. Then what you have in stage 3 is these flattened T waves, they become inverted. That's stage 3. And then stage 4 is that these inverted T waves in stage 3, they now become normal again. And this takes a long time to occur. So these 4 stages are the 4 stages of ST segment and T wave evolution in acute pericarditis.
Sorry again, the PR segment depression, is it consistently depressed all through the 4 stages?
No, it is in stage 1 where you have the PR segment depression. It is not depressed in other stages.
Please, just to add, some text said that stage 1, you can also see a normal ECG. So in stage 1, you can see a normal ECG or those 3 things you called. Then stage 3, it can be T wave inversion or a biphasic T wave. Yes, biphasic T wave or T wave inversion, or you may see that the T wave is biphasic. Thank you.
Thank you, Jay. Thank you. So any other contributions? Okay, if there are no other contributions, can the person project it? Go to question 512.
Sorry, I was trying to unmute. I didn't know I was muted. I want to ask, can you briefly differentiate these changes you see in pericarditis from the changes you see in myocardial ischemia and infarction on ECG? Because are the two that can be mistaken by candidates when they bring up these ST changes and T wave changes. So talking about the stages, can you briefly differentiate or just give a few pointers to differentiate pericarditis from myocardial ischemia infarction?
Okay,
Just a few
one of the
pointers.
things that yes, one of the differences between pericarditis and myocardial infarction is that for patients with acute myocardial infarction, you see that the affected areas will be those areas that the arterial territories, like and septal and all that. That's you will see. Unlike in pericarditis, where what you have is a diffuse ST segment elevation that you see in all the leads, except in AVRO and V1, where you don't see those findings. So that those diffuse ST segment elevation differentiates myocardial infarction from pericarditis. That's one thing. Then another thing that you can. Another thing is that what you have in ST segment elevation is that within there's a T wave within weeks after myocardial infarction. You can have an inversion of the T wave to normal in those with myocardial infarction, while in those with pericarditis, it takes a very long time for T waves to return back to normal. That's what happens. And then also another thing that also happens is that a few hours after myocardial infarction, I think there's an inversion of the T waves in myocardial infarction just hours afterwards. That's what we see in MI. I don't know if there are other differentiating factors that you want to mention.
Okay, what you said are part of the differences, and they are quite important differences too, but there are still some others. But like in the recap you mentioned, in pericarditis, you have diffuse ST elevation all over the place, whereas in MI, it is localized to arterial territories or regions. Okay, and then the other thing that I can also point out there too is that MI will have most times you see the changes in contiguous leads, and then you also see reciprocal changes on opposite leads too, which you don't see in that is everywhere. And then, like mentioned, the T wave is upright in the first stage in pericarditis. In MI with S elevation, most times you have an inverted T wave that follows it, not upright most times. And they have the PR depression in pericarditis, which you don't see in myocardial MI. And then if your ECG in MI can have Q wave in later stages, which you don't see in significant Q waves, later stages you don't see in pericarditis. Okay, so and then there are still some other changes too, which can also help you make a difference. Okay, because so some of the three questions you have in mind is there ST depression in a lead other than the AVR or V1, which you see in MI? So if you see ST changes in AVR V1, it's not likely to be pericarditis, because like you mentioned, you don't see them there. And then the convex or concave ST changes too. Because in MI, the ST changes are most likely convex up or horizontal ST elevation, not the concave you see in pericarditis. And then also you look at list 3 too, because ST elevation, if there's list 3 is part of the list, one list that will involved, you see the greater changes there than the one in list 2. Okay, so and there are some other changes too, but the point is you need to be able to make the difference in the two, because they can give you an ECG of patient having pericarditis and ask you what and it's easy to mistake that for MI, or give you an MI and then you, but most times most people see ECG, everybody's mind goes to MI, forgetting that it can also be pericarditis. So I think we should have those changes in our head, but they don't solve. Like in my exam, or the station, they gave me an ECG. So that can be anybody's station too. So you should be able to make that change. Thank you. I think you can continue, sir.
Thank you, Chief.
Unless some other person has something else to add. Can continue, sir. Unless somebody has something else to add on, can continue, sir.
Oh, okay. Since nobody has said anything. So question 512. Which of the following statements regarding the natural history of untreated aortic stenosis is correct? Average survival from the onset of syncopal symptoms is approximately 6 months. The average survival from the onset of congestive heart failure is approximately 2 years. Syncope due to AS usually occurs at rest. Sudden death in patients with AS usually occurs in previously asymptomatic individuals. Atrial fibrillation is typically well tolerated in patients with advanced AS. So the natural history of symptomatic aortic stenosis has been studied, and what is known is that For a patient with aortic stenosis, once it develops angina and there's no treatment within a space of 5 years, we expect mortality. Also, for a patient with aortic stenosis who has developed syncope, we expect mortality if patient is untreated for a period of 3 years. And then when patients with aortic stenosis develop heart failure, we expect mortality within a period of 2 years. This is the natural history of untreated aortic stenosis. So that makes A wrong. That says the average survival from the onset of syncope is not 6 months. From syncope is 3 years. So angina is 5 years, syncope 3 years, heart failure 2 years. In that order of severity, angina 5 years, syncope 3 years, heart failure. So B is the correct option here. Average survival from the onset of congestive heart failure is approximately 2 years. Yes, B is the correct option. Then C, syncope due to AS usually occurs at rest. That's not true. Syncope usually occurs with exercise, but not at rest, because patients with aortic stenosis, they usually have a fixed cardiac output because of the aortic stenosis. So when they engage in exercise, there's reduced cerebral perfusion because patients cannot increase their cardiac output. So there's reduced cerebral perfusion, and this is what leads to syncope. So it's not something that occurs at rest. Exercise.
Okay. What should come here?
Dr.
Then
Tex.
D, option D is also.
Oh.
Thank you. Sorry, Doctor.
Then option D, sudden death in patients with aortic stenosis usually occurs previously asymptomatic individuals. This is also a false option. Patients who die suddenly with aortic stenosis are those that have been previously symptomatic, not those that have been previously asymptomatic. Because sudden death occurs in those that have critical aortic stenosis, people that have very severe aortic stenosis, and it's impossible for people to have critical stenosis without symptoms. So it's those who have critical aortic stenosis that can have sudden cardiac death. So this option that it occurs in previously asymptomatic individuals is false, because with critical stenosis there will be symptoms. So D is false. Then E, atrial fibrillation is typically well tolerated in patients with advanced aortic stenosis. This is another false option. Those with advanced aortic stenosis, they tolerate atrial fibrillation poorly. The reason is that we know with aortic stenosis, the left ventricle is hypertrophied. And with this hypertrophy of the left ventricle, there's also reduced compliance. The compliance of the left ventricle is poor. So you need atrial contraction to deliver preload and maintain cardiac output. So when patients now develop AF and atrial contraction is not there to deliver preload, it causes significant hemodynamic problems. So this option that says that atrial fibrillation is well tolerated in advanced aortic stenosis is also false. So the correct answer is B. Any contribution? Thank you. Any contribution? Okay, can we go ahead to 513 if there are no contributions?
Yes, sir.
Who's projected 513? Okay, thank you. Thank you. So question 513, a 46-year-old postmenopausal woman, a 46-year-old postmenopausal woman with a history of systemic sclerosis is admitted to the coronary care unit because of progressive dyspnea and chest pain. Initial data include blood pressure of 88/55 millimeter of mercury. Heart rate is 104 beats per minute. Oxygen saturation 95%. General examination is notable for cool extremities and symmetric edema of the lower extremities. The ECG demonstrates right ventricular hypertrophy with a strain pattern. The serum troponin T is 1.10 nanogram per ml. Reference range is less than 0.01 nanogram per ml. And contrast enhanced thoracic computed tomography demonstrates right ventricular cavitary enlargement without pulmonary embolism. Coronary angiography shows minimal coronary artery disease without coronary vasospasm. Right heart catheterization reveals the following: mean pulmonary artery pressure of 61 millimeter of mercury, mean pulmonary capillary wedge pressure of 10 millimeter of mercury. See the other part of the question. I think there's something that is still missing in question. Please, can you take it upward? Okay, mean pulmonary vascular resistance is 16.2 Wood units. Our body surface area is 1.6 meters square. Which of the following is the most appropriate initial treatment for this patient? Okay. So the clinical scenario we have here is that of a patient with systemic sclerosis. And we know that patients with systemic sclerosis is characterized by skin fibrosis, fibrosis of internal organs, microvascular involvement, and they also usually have pulmonary hypertension. Systemic sclerosis usually have subclinical pulmonary hypertension, which can progress. So other things about the question that we have seen here is that the patient's blood pressure is 88/55 millimeter of mercury. So this patient is also most likely cardiogenic shock. Patient also has full extremities. So all these point to cardiogenic shock. And then the ECG has ROVH with strain pattern. The patient, the CT, computed tomography of the CT also shows right ventricular enlargement and there's no pulmonary embolism. And then right heart catheterization was done. Mean pulmonary artery pressure is greater than 20 millimeter of mercury. So this tells us that there's pulmonary hypertension. So the scenario we have here is that of severe pulmonary hypertension with cardiogenic shock. So that's what we are dealing with here. So the options are that we say, what is the most appropriate treatment for pulmonary hypertension with cardiogenic shock? That's the question here. So the options are A, oral macitentan 10 milligrams daily, intravenous epoprostenol initiated at 2 nanograms per kg per minute, tissue plasminogen activator 100 milligrams administered continuous IV over 2 hours, and then the Jobson 0.125 milligrams daily. Okay, and this question I couldn't really. I think I might need some help with the answer to this question. But from the answer I looked at, it says that B is the answer, which is intravenous epoprostenol, which is intravenous prostacyclin, and that the guidelines recommend that this is what should be used for pulmonary hypertension with cardiogenic shock. Option A, oral macitentan, which is a non-selective endothelin receptor antagonist that can also be used for the treatment of pulmonary hypertension, is actually contraindicated for the treatment of pulmonary hypertension with associated cardiogenic shock. So they say it cannot be used in this instance. So I don't know. Maybe if there's somebody that can still throw more light on the question, this can help us.
So I didn't get what you said about the oral macitentan to use.
Okay, the oral macitentan is a non-selective endothelin receptor antagonist. So it is approved for the treatment of pulmonary hypertension. But what I saw in the answer is that it's contraindicated when there's cardiogenic shock. So what you can use in patients who have pulmonary hypertension and cardiogenic shock is an intravenous prostacyclin, which is this option B, epoprostenol. So they say that's what the guideline recommends, but I really don't know the reason why you can't use a macitentan. I don't think there's somebody that can throw more light to this question. Or maybe if there's nobody to throw light,
Although I
read the answer.
that, hello.
I'm with
Hello,
you, sir.
Chief. Hello, Chief Chuka, you can continue, sir. Good evening, sir.
Okay. So we can proceed to the next question.
Yes, please. I think this network. Yeah.
Okay. So question 514. A 45-year-old man is transported to the emergency department, a victim of a stab wound to the chest that occurred during a robbery attempt at his convenience store. Which of the
Hello, Chief Oyema, sir.
following?
Sorry,
Okay,
Doctor.
continue.
Okay. Which of the following statements about
Okay,
penetrating
what I was
cardiac
trying to say,
trauma?
in this condition, part of the issue is understanding the class of pulmonary hypertension that the patient has, whether it is pulmonary hypertension from left heart disease versus that from pulmonary disease, or from. So the cause affects how you treat. And then how you know that, and also whether it's pre-capillary versus post-capillary or combined pre and post-capillary, also that is how you treat the patient and what you use to treat. Because if the cause is more of the pre-capillary, although I didn't get all the things because of the myopia, but I know that we have to consider if the cause of hypertension is more of a pre-capillary thing, then your treatment will not be the same as when it's mostly post-capillary, like secondary to left heart failure, for instance, in which case the problem is more from left heart congestion, pulling back left atrial pressure, pulling back to the lungs, in which case your concern is not going to cause pulmonary vasodilation, and where you are more concerned is to handle the heart flow that the patient has. Whereas if it's more of a capillary or pre-capillary, that's another different ballgame altogether. And that's where some of these drugs can be of importance. And that's why they involve the issue of Johnson to know if we have, because if this were more of post-capillary, the Johnson can be of some use to offload the left heart and then reduce the pressures on the left atrium. So the use of the drugs determines what you use, whether you are going for a pre-capillary, capillary or post-capillary, combined post-capillary hypertension. That means also what drug you use and what can be useful and what will worsen the problem in the patient. But I couldn't get all your saying, so but I believe that is around that and organizing which one it is, and then the guidelines direction which one to use for which patient. Because if you use the wrong drugs, you are the wrong type, then you can worsen the patient's condition. But all the same, you can continue and we look at it that way and then go to the guidelines and match with whatever it is we had. I wasn't able to get all you said.
Okay, thank you. I'll look at it again. So question 514. A 45-year-old man is transported to the emergency department, the victim of a stab wound to the chest that occurred during a robbery attempt at a convenience store. Which of the following statements about penetrating cardiac trauma is correct? A. The left ventricle is the cardiac chamber most commonly injured by penetrating trauma. This option is false. Why it is false is because the right ventricle is actually more anterior in position than the left ventricle. So when patients have penetrating cardiac trauma, the right ventricle is more likely to be affected than the left ventricle. So option A is wrong. Option B, penetrating injuries to the atria are associated with better survival than wounds to the left ventricle. This is also another wrong option because the ventricles have thicker walls than the atria. So if there's a penetrating injury to the ventricles are able to, seal such laceration sites better than the atria, which are not as thick as the ventricles. So people with ventricular penetrating injuries, they have better survival. So to say that the atria is associated with better survival is wrong. Then C, rupture of the interventricular septum is the potential late complication. C is actually the correct option. Patients could actually have rupture of the interventricular septum as a late complication of penetrating chest trauma. D is also wrong. In penetrating cardiac injury with suspected tamponade, urgent pericardiocentesis is mandatory. It is not mandatory. In fact, most trauma surgeons do not advise this because usually with penetrating chest trauma, there can be bleeding into the pericardial sac. But if you do pericardiocentesis, the thing is that there is usually clotting of blood in the pericardial sac. So with pericardiocentesis, it's very difficult for you to drain out those blood clots with a needle. So it's just going to be something that you will have to do repeatedly if you want to do pericardiocentesis, and it's not of much benefit. So when patients have penetrating chest trauma and you see that they have increased JVP, they have muffled accents, they have cardiogenic shock, all these signs pointing to cardiac tamponade, the best thing to do is to proceed to thoracotomy, and evacuate those blood clots to the pericardium. Pericardiocentesis is not mandatory, and it's not the best form of treatment for pericardial leading into the pericardial sac, from trauma. So D is also wrong. The correct option is C. Any contribution? Any contribution?
Go on.
Okay, can we proceed to question 515?
Yes, yes.
Okay,
Let's
you, Chief.
proceed.
Okay, so question 515. Which of the following statements regarding persistent patent ductus arteriosus in adults is correct? A, in patients with PDA, the pulse pressure is typically reduced. Patients with moderate size PDA typically have an isolated diastolic murmur. The murmur of PDA is best appreciated just inferior to the right clavicle. D, even small silent PDA shock present a high risk of endovascular infection. E, the success rate of transcatheter occlusion of PDA is greater than 98% over long-term follow-up. So we know that in the fetal circulation, the patent ductus arteriosus, when the pulmonary circulation is not yet active, there's shunting of the blood, that comes into the right atrium, right ventricle, into the left. That's what happens in the fetal circulation. And the PDA is supposed to close at birth, but sometimes it may not close and people may have a persistent patent ductal arteriosus. And what happens is that the presentation of a PDA actually depends on the degree of the left to right shunt. So if you just have a small silent shunt, a PDA with a small silent shunt, you see that this group of patients are almost always asymptomatic. It's usually going to be an incidental finding on echo, and the risk of endovascular infection is very low in this group of patients. So this option D, where it is said that even small silent PDA shunts present a high risk of endovascular infection, D is false. Patients with small silent shunt, the risk of endovascular infection is negligible. It's something that they can just find incidentally on echo. So that's for small silent shunt. Then you also have those small audible shunts. I just talked about small silent shunts. They are asymptomatic. Risk of endovascular infection is low. Then when you have small shunts that are audible, these patients are also usually asymptomatic, but occasionally they may have symptoms because they may have endovascular infection, those with small audible shunts. Then another thing, when you now have a moderate shunt, when you have a PDA with a moderate shunt, what happens is that this will increase the load in the left ventricle and the left atrium, and this will result in left ventricular dysfunction and atrial fibrillation. So this group of patients with moderate shunt, PDAs with moderate shunt, these patients will be symptomatic. Unlike those with small shunt that are asymptomatic, those with moderate shunts will be symptomatic. They will have dyspnea, they can have palpitations, they can have atrial fibrillation. And what you have in those with moderate shunt is that even on physical examination, you'll find a murmur, and the murmur is described as a loud, continuous machinery murmur. So there's something here. Option B, where they say patients with moderate size PDA typically have an isolated diastolic murmur. B is false. B is false. What you have in these people is a continuous murmur. It's not a diastolic murmur, a loud machinery continuous murmur. So it's not an isolated diastolic murmur that you have in moderate size PDA. So option B is wrong. Then also, those who have large shunts, PDAs with large shunts, is the same thing that you have in moderate shunt. There will be left ventricular overload. So this will lead to left ventricular dysfunction and symptoms. But what differentiates the moderate shunt from the large shunts is that those with large shunts, they now usually develop irreversible pulmonary hypertension and Assessemt physiology, the reversal of the shunt. So that's what you see in this group of people. And the teaching is that for symptomatic PDA, these people with moderate and large shunt that are symptomatic, it is recommended that they should be closed. These people should receive treatment, except they now have a Assessemt physiology, in which case you cannot close. But without that, you are supposed to close once your PDA is clinically detectable. So this option E is actually the right option. The success rate of transcatheter occlusion of PDA is greater than 98% over long-term follow-up. It is said that when Amplaza devices are used to close PDAs, that the success rate is at least 98.1% on long-term follow-up. So this is the correct option. Option A is wrong. Say in patients with PDA, the pulse pressure is typically reduced. No, there's a wide pulse pressure in patients with PDA. So A is wrong, B is wrong, C is wrong. There's C. I haven't talked about C. The murmur of PDA is best appreciated just inferior to the right clavicle. Below the right clavicle is not the site of where you hear the PDA murmur. The PDA murmur is heard in the first and second left intercostal space. That's where you hear the loud, continuous machinery murmur. So option C, where it is said that is the right clavicle, is false. Is the left first and second intercostal state. That's where you hear that moment. So A, B, C, D are wrong. The true option here is E. Any contribution? Any contribution? Okay. Can we progress?
I should think so. I should think so.
Okay. Okay. So question 516. A 46-year-old man is admitted to the hospital because of worsening shortness of breath. His history is notable for hypertension, treated with an angiotensin converted enzyme inhibitor. Social history reveals that he has consumed half a pint of Lycor daily for the past 10 years. Physical examination shows an elevated jugular venous pressure of 14 cm by basal rails. Can you project? Can you take it up? Can you take it upward? Yes. Okay. By basal rails on pulmonary examination, thank you. A laterally displaced cardiac apical impulse, a grade 2/6 holosystolic murmur, an S3 gallop at the apex, and pitting edema of both lower extremities. Echocardiography demonstrates a dilated left ventricle with an ejection fraction of 25% and moderate mitral regurgitation. Which of the following statements regarding the cardiac effect of alcohol is correct? From the question here, this patient has a history of alcohol intake for the past 10 years, daily alcohol intake for the past 10 years. We're now seeing features of heart failure for this patient. Heart failure with a reduced ejection fraction. So most likely what we are dealing with here is an alcoholic DCF, an alcoholic dilated cardiomyopathy. So for the option, chronic heavy alcohol consumption is associated with low systemic blood pressure. This is obviously false. What we have with chronic heavy alcohol consumption will rather raise the blood pressure, not giving us a low blood pressure. So option A is wrong. And I would see the other option. Okay. You see the likelihood of developing dilated cardiomyopathy correlates with the amount of alcohol consumed over a lifetime. I think B is the correct option here. The likelihood of someone developing alcoholic DCM, it correlates with the amount of alcohol that you consume over a life. I think they even gave a figure of like if you consume up to 90 grams of alcohol daily for a period of 5 years, you are likely to develop alcohol DCM. I think this is the right option. Then question C says women are less susceptible than men to alcohol-associated cardiomyopathy. This is a false option. In fact, the reverse is the case. If women and men are consuming the same amount of alcohol, women are more likely to develop DCM at the same level of alcohol consumption as men. Women have smaller quantities of alcohol, dehydration, and are not able to break it down as much as men. Women are more susceptible, not less susceptible. So question option C is false. And they say moderate alcohol consumption is associated with an increased rate of sudden death. This is false. In fact, moderate alcohol consumption confers cardiovascular benefits. Those who consume alcohol moderately and who do not have coronary artery disease, it's been found that they have a reduction in cardiovascular mortality, and they also have a lower incidence of sudden death. But if there's chronic heavy alcohol consumption, that can lead to sudden death. On the other hand, moderate consumption leads to reduced cardiovascular mortality, including reducing of sudden death. I think this is where that alcohol, some alcohol consumption has some cardioprotective effects. Then option E, dilated cardiomyopathy due to alcohol consumption, irreversible. This is also a false option. So A, C, D, and E are all false options. B is true. Dilated cardiomyopathy is actually reversible. When patients who consume alcohol, they now stop alcohol consumption, especially in the first 6 months. Their left ventricular systolic and diastolic function improve dramatically. There's a dramatic improvement in left ventricular systolic and diastolic function upon stoppage of alcohol consumption. So it is not irreversible. If patient stop alcohol consumption, they can have improvement left ventricular systolic and diastolic function. Any contribution for question 516?
Well, it's clear.
Sir?
Okay, thank you, Dr. Brown. Regarding alcohol and the heart, I don't know what year this MCQ we're using was published, but in 2021, the World Heart Federation published a statement after putting together many studies on alcohol and cardiovascular system, and the conclusion from that was that no amount of alcohol is the long-term beneficial to the cardiovascular system. I think we shared the document on the WhatsApp group. Perhaps I could refer to it. I don't know if all cardiovascular bodies have adopted this or, supported the statement, but it's, I think.
There is another study that comes that one.
Okay.
Well, can I?
That's fine. We could still look at the document.
I
think it
yes,
wasn't from one study. They put together a lot of.
Actually, there is no consensus on that. There are two different schools of thought. Okay, Chick, I wanted to say something.
Okay, what I want to add was I'm aware that most textbooks, by the time they are published, some of them are 4 or 5 years outdated with present current information. And this Braunwald most likely may have the same problem that by the time it's coming out of the press, it's already outdated with current information. So this information about modern alcohol being good, I've been debate for a while, and I think like the earlier speaker said, like said, that the current consensus that even though the argument is still going on, for current publication and the stand of the World Heart Federation is more on the fact that no amount of alcohol is beneficial to the heart. There are still some agreements here and there, but that's but however, we want us to be sure look for those consensus guidelines on it, so that you go to the exam having a particular statement on that issue. I don't want to take my word for it, but at the time the history was published and waiting, that information is currently there are papers saying no alcohol is good. At the same time, like Dr. Ewing said, there are also some that are trying to counter it, but we need to find what the consensus is, especially what is inside of the World Heart Federation, the Individual Society of Cardiology, AAG, and then Nigerian Society. We have to, because as if you come to the exam and this comes up, you can have a stand for your answer to the question. Even though I believe that something that is controversial, but then there's still a possibility on the current consensus guideline that we have available at this time.
For that clarification, thank you.
Thank you so much for that clarification. Information, yes, really outdated. So can we progress to question 517? Can we?
Yes.
Please,
Okay.
yes.
Okay. Expected clinical manifestations of amyloidosis of the cardiovascular system include which of the following? Option A, constrictive pericarditis, high output heart failure, C, orthostatic hypotension, D, ECG voltage criteria for the ventricular hypertrophy, E, is electrical alternate. Okay, option A is actually false. What happens? The pathophysiology in amyloidosis is that there's the position of amyloid protein in the cardiac myocardium. And with the deposition of this amyloid protein in the cardiac myocardium, what you have is a restrictive cardiomyopathy with impaired filling and diastolic dysfunction, not pericardial constriction. Pericardial constriction is actually rare in amyloidosis. What you have is a restrictive cardiomyopathy, so A is wrong. High output heart failure, no. That's not what we have in amyloid heart failure. Not a high output failure like you see in those with anemia, those you see with dairy and all those things that cause high output failure. What you have is actually a right-sided heart failure, which may also subsequently involve the left. The correct option actually is the orthostatic hypotension because amyloid proteins are also deposited in the autonomic nervous system. And with the deposition of amyloid proteins in the autonomic nervous system, patients can, about 10% of patients with amyloidosis can actually develop orthostatic hypotension. So that's the correct option. D is ECG voltage criteria for left ventricular hypertrophy. Of course, this is false because the usual ECG presentation you see in cardiac amyloidosis is actually low voltage complexes, not LVH. And also electrical alternance is false because electrical alternance is what you see in pericardial disease, pericardial effusion, when the heart is swinging in fluid. That's when you see electrical alternance. But there's no significant pericardial disease in cardiac amyloidosis. So E is also for contribution. Can we progress to question 518?
Yes,
Okay,
please.
so thank you. Which of the following statements regarding endocarditis caused by Staphylococcus aureus is correct? A, central nervous system complications are rare, occurring in fewer than 5% of patients. Staph aureus native valve endocarditis is an absolute indication for surgical debridement. The prognosis of right-sided Staph aureus native valve endocarditis is similar to that of left-sided involvement. D, empirical therapy with oxacillin or cefazolin is appropriate for suspected Staph aureus endocarditis. Prosthetic valve endocarditis with Staph aureus is associated with a 50% mortality rate in patients treated medically. So for option A is wrong. Staph aureus endocarditis is frequently metastatic. Most times when there is Staph aureus infection of the cardiac valves, is metastatic, and you can have 30 to 50% of CNS metastasis in Staph aureus endocarditis. So this fewer than 5% is the wrong option. What you have is actually 30 to 50% metastasis. They say Staph aureus native valve endocarditis is an absolute indication for surgical debris, but that's not true. It is better to try medical therapy first, because if you rush and proceed to surgery in patients with Staph aureus endocarditis, and the native valve is removed with a prosthetic valve attached, is a problem. You have to sterilize the blood first before you can even put another valve. So it's not an absolute indication. You have to try medical therapy first, because if you just proceed to surgery and the prosthetic valve, there's an high mortality with Staph aureus prosthetic valve endocarditis. So that's why E is even the correct option. Prosthetic valve endocarditis with Staph aureus is associated with a 50% mortality. That's true. That's true. So patients treated medically. So if it is a native valve, you treat medically first, because if you go for surgical and the prosthetic valve is infected without sterilizing the blood, you are in for trouble. So B is false. And the prognosis of right-sided Staph aureus native valve endocarditis is similar to that of left-sided. That's false. Prognosis is not similar. Those with right-sided Staph aureus endocarditis have a better prognosis than those with left-sided. Possibly because of the risk of CNS metastasis, those with left-sided. So it falls in left-sided. It's not similar, so C is a false option. Then initial therapy with oxacillin or cefazolin is appropriate. That's also false. That shouldn't be empirical therapy, except you have cultured the organism and you have a sensitive antibiotic that you want to use. That's where you can go for a definite antibiotic. But if you are doing empirical therapy, it has to be with vancomycin, because it's been found that both in nosocomial, hospital-acquired infections, and community-acquired infections, methicillin-resistant Staph aureus is the common cause of endocarditis. So if you are doing empirical, it's better to start with vancomycin until you have a blood culture result where you can now go for a definite antibiotic. So options A to D are all false, and the correct option is E, which states that there's a high mortality associated with prosthetic valve endocarditis with Staph aureus. That's the true option. Question 5.8. Any contribution? So can we proceed to 5.9? Someone want to throw more light? Okay, question 5.9. Which of the following mean pulmonary artery pressure, pulmonary vascular resistance, and pulmonary artery wedge pressure profile on right heart catheterization is consistent with isolated pre-capillary pulmonary hypertension? So a lot of figures have been given there. So our job on this question is to find out which of these values are indicative of isolated pre-capillary pulmonary hypertension. What are meant to detect here. So pulmonary hypertension can be divided into three hemodynamic categories. You have pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension. Then you have the combined, that's isolated pre-capillary, isolated post-capillary. Then you have the combined pre and post-capillary. So how do you differentiate them? For the three of them, the mean pulmonary artery pressure would be greater than 20 millimeter of mercury, which is what you have here for all of the mean pulmonary artery pressure greater than 20. So that tells you that there's pulmonary hypertension. And how do you now differentiate? For pre-capillary, the pulmonary vascular resistance will be greater than 3 Wood units, while the pulmonary capillary wedge pressure will be less than or equal to 15 millimeters of mercury. And the reverse is the case for post-capillary pulmonary hypertension. The pulmonary vascular resistance will be less than 3 Wood units, while the pulmonary capillary wedge pressure will be greater than 50 millimeter of mercury. Then for combined, you now have both the pulmonary vascular and the pulmonary capillary there is above 3 Wood units. This one is above 15 millimeter of mercury. That is combined with the mean pulmonary artery pressure of greater than 20 millimeter of mercury. So the question they ask us is for isolated pre-capillary. So I've mentioned before that pre-capillary mean pulmonary artery pressure greater than 20, pulmonary vascular resistance greater than 3 units, pulmonary artery wedge pressure less than or equal to 15. So if we look at the pulmonary artery wedge pressure, only option B has a pulmonary wedge pressure less than 15. Mean pulmonary artery pressure is 23. Pulmonary vascular resistance is 3.1, which is greater than 3. So B is the correct option. This is important, like Dr. Chief mentioned earlier. It's important for you to, when you have a patient with pulmonary hypertension, to distinguish whether you are dealing with a pre-capillary or post-capillary, because this will help you with the etiology of pulmonary hypertension.
I don't know whether it's the network from my side or your own. I didn't get your details on the distinguish.
Okay, for pre-capillary, for all of them, for pre-capillary, post-capillary combined, you have a mean pulmonary artery pressure greater than 20 millimeter of mercury, suggesting that there's pulmonary hypertension. So to now differentiate them, for the pre-capillary, the pulmonary vascular resistance will be greater than 3 Wood units, while for post-capillary, it will be less than 3 Wood units. For pre-capillary, the pulmonary capillary wedge pressure will be less than or equal to 15. For post-capillary, it's greater than 15. So pre-capillary and post-capillary, they are just opposite of each other.
Okay.
Pulmonary vascular resistance greater than 3 Wood units for pre-capillary, less than 3 Wood units for post-capillary. Pre-capillary has a pulmonary capillary wedge pressure of less than or equal to 15. Post-capillary greater than 15. They are just opposite of each other, pre-capillary and post-capillary. While the combined, both values are elevated. Pulmonary vascular resistance is greater than 3. Pulmonary artery wedge pressure is greater than 15.
So from what you said now, what differentiates the combined and then the pre-capillary?
Okay. What differentiates pre-capillary and combined? The both of them, the pulmonary vascular resistance is greater than 3 Wood units. For pre-capillary, the pulmonary capillary wedge pressure is less than 15, while it's above 15 for combined. Did you get it, sir?
Yes, I do.
Okay. So that's how to differentiate them. And so the question they ask us here is, which of these values are consistent with isolated pre-capillary? So it's pre-capillary. So pre-capillary, the definition is mean pulmonary artery pressure greater than 20, pulmonary vascular resistance greater than 3 Wood units, then pulmonary capillary wedge pressure less than 15. That is the one that will be consistent with pre-capillary pulmonary hypertension, which is option B, where the pulmonary vascular Wood units is 3.1, while the pulmonary artery wedge pressure is 13, less than 15. So this is consistent with pre-capillary. If you come to A now, the pulmonary vascular unit is less than 3, and then pulmonary artery pressure is 21. So that's post-capillary. A is post-capillary. If you come to C, the pulmonary vascular resistance is greater than 3. Pulmonary artery wedge pressure is greater than 15. So this is combined. Both of them are elevated, so it's combined. If you come to D, the pulmonary vascular resistance is 1.9, which is less than 3. And then the pulmonary artery wedge pressure is 26, greater than 15. So this is post-capillary. So B is the pre-capillary.
Thank you. That's detailed.
Okay, so thank you, Dr. Brown. Let me just make a little clarification. I think 2 days ago or so, we did a question and spoke about the updated guidelines for pulmonary hypertension. The ESC 2022 brought down the cutoff value for the Woods unit to 2 Woods unit, but I think the American guideline still uses 3. So just so we're not confused compared to the previous discussion. Then I don't know if you could check the answer, because I think you gave us A as the answer, but if you could just check the answer they gave in the book. Oh, B. Oh, okay, fine. So just the Wood unit cutoff is the difference between the European and American guidelines. They both use MPAP of 20 and pulmonary artery wedge pressure of 15. But the Woods unit, the ESC 2022 uses 3. And I think it uses 2, brought it down to 2 Woods unit, while the American uses still uses 3 Woods unit.
Thank you. Okay. So any more contributions to question 519? If there are no more contributions, can we proceed to 5.8?
Hello.
Okay. Yes, thank you, Jim. A 43-year-old man from Uganda is diagnosed with low-class endocarditis. Which of the following is an expected finding? A hypertrabeculation of the left ventricular myocardium, accompanying aortic dissection, asthma and nasal polyposis, eosinophilia, markedly reduced left ventricular ejection fraction. Low-class endocarditis actually usually occurs in temperate climates. It occurs usually in males. It occurs usually in the 4th decade. And the defining feature is persistent eosinophilia greater than 1,500 millimeter cube for at least 6 months, with evidence of organ involvement. And then cardiac manifestations are seen in 75% of patients. So these are the features of low-class endocarditis. A option says hypertrabeculation of the left ventricular myocardium. That's not the pathology you see in low-class endocarditis. What you see is endocardial thickening, at the left ventricular inflow and apical portions. Then on histology, you have an inflammatory myocarditis with predominant eosinophils. And there's also thrombosis and inflammation of intramural coronary vessels. There's also a fibrotic thickening of the ventricular wall. These are the pathologic features. I know that hypertrabeculation is usually something that we see in left ventricular non-compaction and not in low-class endocarditis. Accompanying aortic dissection, no, there's no aortic dissection. Asthma and nasal polyposis is also false. Something that is similar to low-class endocarditis is Shock-Strauss syndrome, which is a small vessel vasculitis, where you have where you also have eosinophilia and cardiac involvement. But in Shock-Strauss, in addition to the hypereosinophilia and cardiac involvement in shock stress. There's also presence of asthma, nasal polyposis, and necrotizing vasculitis. Shock stress is an anchor positive vasculitis. So asthma and nasal polyposis is what you see is associated with shock stress and not with Loeffler's endocarditis. So C is wrong. So the correct answer here is actually D, which is the eosinophilia. So A is wrong, B is wrong, D is wrong. Asthma is associated with shock stress. Eosinophilia is what is common to Loeffler's endocarditis. And also, it's been found that the left ventricular systolic function is usually not those with the Loeffler's endocarditis. They don't have left ventricular systolic dysfunction. Those will what you have, the consequences of the pathology of Loeffler's endocarditis is that there's endocardial scarring, and this scarring usually leads to a restrictive cardiomyopathy. So what you have is abnormal diastolic function, impaired feeling. That's what you have in Loeffler's endocarditis, and not systolic dysfunction. So this makes option E that says that marked reduction of left ventricular ejection fraction, reduction left ventricular ejection fraction, normal diastolic dysfunction, you'll find. And the treatment of Loeffler's endocarditis is usually, apart from treating the heart failure, they are giving steroids and hydroxyurea. That's what they are giving. Thank you. Any contribution?
Thank you very much, Dr. Brown. Please, do we have any contribution from the class? Okay, Dr. Brown, thank you so much for coming up to take your part. I'm happy to announce that we are almost there. We only have 10 more questions to finish in Braunwald. So please, Chief Alagbe, can we go to 531 to 540? Chief Uzoke, please, are you there?
Good evening, everybody. Sorry, I had to climb several trees today to have access to network. I just hope it becomes steady going forward.
I was about asking that. I hope it's a mango tree, because that's the only verified tree by Chief Okope that has network.
So sorry. So sometimes it's very frustrating. Come in, I get logged out. Come in, I get logged out and all that. But finally, we are here. Good evening, everybody, once more. Question number 531. A 36-year-old woman with repaired tetralogy of her lobe presented for routine outpatient evaluation. She underwent surgical heart repair at age 5 months, including ventricular septal defect closure with a Dacron patch and a relief of right ventricular outflow tract obstruction with annular patch. She denies shortness of breath or presyncope. Her ECG demonstrates normal sinus rhythm with intravascular conduction delay, QRS duration being equal to 190 milliseconds. Cardiac MRI reveals a low normal left ventricular ejection fraction, severe pulmonary regurgitation, right ventricular dilatation with moderate right ventricular systolic dysfunction and moderate tricuspid regurgitation. Cardiopulmonary size testing shows that her maximal oxygen consumption is 56% of the predicted value for her age and body surface area. Which of the following statements is correct? She should be referred for pulmonary valve replacement. Her risk of sudden cardiac death is low. The presence of tricuspid regurgitation in this case does not influence the risk of developing atrial arrhythmias. She does not require antibiotic prophylaxis prior to procedure prior to dental procedures. Now, We'll take the options one by. She does not require antibiotic prophylaxis prior to dental procedures. That is not correct. This patient had a structural heart repair at age 5 months, with some residual anomalies, which includes the Dacron patch. So this is still a high-risk patient. So it requires antibiotic cover for or before oral dental procedures. Now, the presence of tricuspid regurgitation in this case does not influence the risk of developing atrial arrhythmias. Of course, this is not correct, because with the tricuspid regurgitation, there will be both dilatation of the aorta and the right atrium and the ventricle, giving room for subsequent dilatations and arrhythmias in future. Her risk of sudden cardiac death is low. That is not correct, because by
Chief was okay. Okay, so sorry. I think his network went unstable. They didn't climb the mango tree. Chief Uzoke, are you back, please?
Hello, can you still hear me?
Yes, we can hear you now. Please, you have to locate the mango tree itself.
Hello.
Hello, we can hear you. Can you hear us? Wow.
Hello.
Chief Uzoke, we can hear you, but can you hear us? Go ahead.
My God.
Sorry, I don't know whether it's can any other person hear me, please?
Yes, we can hear you.
Okay, thank you, sir. Thank you, Chief Examiner. And this.
Hello.
Hello, Dr. Uzoke.
Hello, can you hear me now, please?
Yes, we can hear you now.
Yes, can you hear me now?
Yes, please, sir, we can.
Wow.
Oh.
All right. So the risk of sudden cardiac death is low. That is not correct, because by the time we have arrhythmias, the risk of sudden cardiac death more so increases. So the most correct answer here is A, which is she should be referred for pulmonary valve replacement. Thank you very much. I don't know if there is any clarification that any more contribution to the whole discussion, to the listing. Which otherwise I move to the next question. Can you help me scroll up, please? 532. I hope I'm still audible, please.
Yes, sir, you
Hello? All right, thank you very much. Question number 532. Now, a 68-year-old man presents for evaluation of progressive dyspnea. He has an extensive smoking history. Pulmonary function test is consistent with severe airway obstruction. Resting arterial blood gas analysis demonstrates a partial pressure of oxygen of 54 millimeters of mercury. An echocardiogram shows normal left ventricular systolic function, right ventricular hypertrophy and dilatation. Hey, noise at the background. And an elevated estimated pulmonary artery systolic pressure. Which of the following there are excuse me. Which of the following therapies would improve the outcome in these patients? Now, we will realize that this patient has elevated pulmonary pressure. So there is already some sort of pulmonary hypertension here. But we realize that this man has COPD that is preceding that elevated pulmonary artery pressure. So hello.
Welcome back.
Hello.
Hello, welcome back, Chief. It's okay.
Thank you. I can hear you. Thank you very much. So I should go on, right?
Yes, sir.
Can you hear me? Should I proceed?
Yes, sir.
All right. All right. All right. So here we have increased pulmonary pressure that is a sequelae of COPD. So what drugs should we give here? Of course, you know that the digoxin doesn't give any elongation. Bosentan would have made sense if we are just treating pulmonary hypertension alone. Theophylline could help, but not necessarily improve the longevity of the patient. Beta-adrenergic agonists, that should be better too. This may help, but not necessarily prolong. But what studies have demonstrated very well here is oxygen therapy, that this helps in the outcome and the longevity of the patient with pulmonary hypertension secondary to COPD. Thank you very much. More contribution, please. Otherwise, could we move to 533 while people get ready with their questions if they have more for me or more contributions to the discussion?
Please, let's move on, sir.
Okay.
Hello, could you please scroll to 533?
Please, still on that pulmonary hypertension definition. So I just rechecked. There's a more recent AHA that uses 2 Woods unit that is similar to the European. So now they're the same.
Am I still audible, please?
3 Woods unit because it was the older guideline. So just to update that.
Thank you so much, Dr. Rukayat. So now
it can be a bit confusing because we need to look at the more recent ones and know some of the differences with the older ones in case it comes up, or we meet an examiner that is not familiar with one or the other or something like that.
Yes. So in summary, what you've said now is that the AHA2 is saying the same thing as ASA for the new classification.
Yeah, so the AHA 2023 statement.
Do you see me, please?
Okay. Thank you so much, Dr. Okay. Dr. Sri, we can hear you, but can you hear us?
Yeah, very well, very well.
Okay, please continue.
Question number 533. Which of the following statements regarding coagulation of the aorta is correct? It is more common in females, which is not correct. It's commoner in male. In fact, it is about 2 to 5 times commoner in males than females. Most children with coagulation are asymptomatic. That statement is correct. Most of them are asymptomatic. That's why sometimes we diagnose them in the adulthood. And a small minority of adults with coagulation also have a bicuspid aortic valve. That's not true. Over 50% of the, in fact, they say 50 to 58 to 85% have a bicuspid aortic valves. And mean survival time in the presence of uncorrected coarctation is similar to the mean survival time of healthy individuals. Of course, we know that this one is not correct because these people developed hypertension early with complications, and I think they say they have a life expectancy about 20 years or so, shorter than their peer that doesn't have a coarctation. Thank you very much. But certainly what is very clear is that they have a reduction in the survival time compared with the healthy individuals. Thank you very much.
Thank you. So what's the
If
answer,
anyone is
sir?
trying to make a contribution, let them be coming up, but the person managing the screen should move to 534 before my network. The answer is B. Most children with coarctation are asymptomatic. That's the correct answer.
Thank you, sir.
Others are false. Can we move to 534, please? Before with my unstable network and all that. Thank you. A 30-year-old woman presented to the hospital after a recent transient neurological event consistent with a small cerebral embolism. During her evaluation, a transthoracic echocardiogram was performed. An apical four-chamber view from the study is displayed in figure 4.31 with panels from both systole and diastole. Which of the following statement is true? Can you please help me go to the fig 4.31, please? Thank you very much. Fig 4.31. It is above the question. It's above the question, not below. Above, up. Yes. Good. Now, if we look at this apical four chamber, if we look at the first fig 4.31, at systole, we have left ventricle, left atrium, right ventricle, right atrium. We see a mass inside the left atrium, and the mass is fairly homogeneous, save for when you get to diastole, you realize that there is a necrotic center, a kind of a more lucent area. Otherwise, it is fairly homogeneous. By the look of this mass, it means it looks like a tumor, because if it were to be embolus, thrombus, it's supposed to be more or less like layered in nature and not this way. It appears to be attached to the septum, because you can see that in diastole that it's actually obstructing the mitral valve inflow into the left ventricle, and the stalk still extends to that to the septum. I think that's what I can say for this. Can we go back to the question? Let us see the options again. Thank you. Thank you very much. All right, thank you. The echocardiographic appearance is most consistent with intracardiac thrombus for the reasons aforementioned. It is not. This condition is commonly associated with fever, malaise, and an elevated erythrocyte segmented rate? Well, we know that 80 and above percent of the tumors that occur in the left ventricle are asymptomatic. So one tends to say that this tumor is is not a malignant. So one is more inclined to say that this tumor is not malignant, and that it is most likely, what's the name again?
Atrial myxoma.
Atrial myxoma, yes. Atrial myxoma, yes. Atrial myxoma. I know that atrial myxoma is associated with those constitutional symptoms of fever, malaria, and elevated erythrocyte segmented rate because of the inflammatory triggers in the system. Surgery is indicated if only if there is hemodynamic compromise. That is not correct. The minority of such lesions are familial. Majority, no, it's not true. It actually occurs in 0.0 something percent. It's not familial for the much I know. This lesion most commonly arises in the right atrium. No, it is commonly in the left atrium. Thank you very much. I think this just goes to recap our previous discussion on the cardiac tumors.
So which one is the answer now?
The answer is B. This condition is commonly associated with fever, malaria, and elevated erythrocyte segmentation rate. Thank you, sir.
Okay, please, just to add, there's the sound that this atrial myxoma causes is called tumor plump. It's actually due to it's because of this picture. That's why I remember this. During diastole, the mass tends to press against the valve. So immediately the left ventricle is trying to fill, then you hear a diastolic murmur, high-pitched sound, which is called tumor plump. Thank you.
Thank you very much, sir. Can we proceed to the next question, please? Thank you. 534. Even for this poor network, I thought that we'll finish very early today. Yes. 535. Thank you. A 54-year-old woman with chronic kidney disease presents to the emergency department because of sudden shortness of breath and right-sided chest pain. Right-sided chest pain. She has no recent history of immobilization, surgery, or travel. The serum creatinine is elevated and precludes performing a chest-computed tomographic angiogram. Which of the following results is most useful in excluding the diagnosis of pulmonary embolism? Oh, yes. Okay, thank you. Can we go to the options, please? Okay. Normal partial pressure oxygen pressure by arterial blood gas analysis. We know that several things can affect this. Pulmonary embolism, community-acquired pneumonia, and several other things can actually alter this. So it not necessarily support pulmonary embolism per se. Normal cardiopulmonary examination. You can still have normal cardiopulmonary examination without, even when there is presence of pulmonary embolism. So this is not correct. Intermediate probability ventilation perfusion lung scan. Not very sure of this. Normal plasma level of D dimer. Certainly, yes. If we have normal plasma of D dimer, the pulmonary embolism is almost totally excluded. Absence of S1 Q3T3 pattern on ECG. I think this occurs in about 25% of the cases. So the correct answer here is normal plasma level of D dimer. Thank you. If there are no further contributions, I'll move to 536. Which of the following statements regarding primary tumors of the heart is correct? Benign tumors are less common than malignant tumors. Of course, this is not correct at all. Malignant tumors is only about 20% or thereabout. The rest are benign tumors. The most common malignant cardiac tumor are lymphomas. Of course, this is not correct. The commonest is sarcomas. Number one is angiosarcomas, followed by rhabdosarcomas, before we start talking about the lymphomas. The majority of benign cardiac tumors are papillary fibrangiomas. Let's put that on the whole. And this says malignant tumors are more likely to occur on the right side of the heart. That is correct. Malignant tumors have the predilection for right atrium, as against benign tumors that have predilection for left atrium. So the answer here is D. Malignant tumors are more likely to occur on the right side of the heart. Thank you very much. Now, 537. It's a 7-year-old man with adenocarcinoma of the lungs presents with dyspnea and weakness. Physical examination is notable for hypotension with pulsus paradoxus and jugular venous distension. An echocardiogram is ordered. Each of the following statements regarding the echocardiography in cardiac tamponade is true. Cardiac tamponade. A. On inspiration, there is augmentation of transmitral flow velocity and reduction in transtricuspid flow velocity. Let's keep that on a hold. B, the absence of right ventricular diastolic collapse ensures that the pericardial pressure is not elevated. That one is not correct. At least B is certainly not correct. C is right ventricular diastolic collapse is more specific than atrial compression in the diagnosis of tamponade. I think I go with that. I stay with that C. But let me still finish with all the options. Right ventricular, okay, no. Cardiac tamponade is associated with normal inferior vena cava collapse with inspiration. That's not true. A small volume pericardial effusion observed on echocardiograph excludes the presence of tamponade. No, if it is loculated, it may not be, it can actually be loculated and stay at the place where the echo cannot get it. So that is not true. E is not true. D is not true. Yes, A is not true. Augmentation of transmitral flow velocity is augmentation and reduction in transtricuspid. That's not true. Now, let's look at B and C. B says the absence of right ventricular diastolic collapse ensures that pericardial. No, B is not correct. So the answer is C. Answer is C. Right ventricular diastolic collapse is more specific than right atrial compression in the diagnosis of tamponade. Yes, the answer is C. Thank you very much. In absence of further contributions, I read question number 538. This is 4-year-old woman with a remote history of mantle field radiation for Hodgkin's disease, presents with gradually progressive symptoms of fatigue, abdominal bloating, and lower extremity edema over the past 4 months. A lateral chest radiograph is shown in Fig 4.32. Which of the following findings would be most helpful to distinguish between the most likely diagnosis and restrictive cardiomyopathy? Can we have a look at the figure 4 points? Good. Okay. If you look at this is the lateral chest radiograph. Yes. Yeah, good. Look at that. Look at the cursor now. The cursor outlines the calcifications. Good. Look at that cursor. It outlines the calcifications of the pericardium. So we have constrictive pericarditis here. Now they're asking of question between constrictive pericarditis and I think they say restrictive cardiomyopathy. Let's go back to the question again. Thank you very much. 1. Kussmaul sign. I think both have it, yes. Both observe it. 2 is, that's 538 now. Hepatomegaly, both can have it. C is right and left ventricular systolic pressure discordance with inspiration observed during cardiac catheterization. This is correct. There is discordance in pericardial effusion as against restrictive cardiomyopathy where there is no compliance in both the ventricles, right and the left ventricles. D, elevation of ventricular diastolic pressure with diastolic dip and plateau configuration. Both experiences this. So the answer is C. C. Right and left ventricular systolic pressure discordance with inspiration observed during cardiac catheterization. Thank you very much. In absence of further comments or contribution, can we move to question number 539? Thank you. Which of the following statements regarding the causes of aortic stenosis is true? A bicuspid valve is present in approximately 25% of patients undergoing aortic valve replacement in aortic stenosis. B, there are no established risk factors for the development of calcific aortic stenosis of a trileaflet valve other than age. That's not correct. Calcification of congenitally bicuspid or normal trileaflet valve is the most common cause of aortic stenosis in adults in the United States. D, isolated rheumatic deformity of the aortic valve without mitral valve involvement is more common than rheumatic involvement of both valves. D is certainly wrong. In an environment, as we had stated earlier, is rheumatic involvement, commonest is mitral, followed by mitral and aortic, then aortic alone, then tricuspid, then pulmonary. So D is out of the way. So now we have A to C. Now, A is correct. The ratio is actually beyond, over 50. You get? So then we are left with B and C. Now, B says there are no established risk factors for development of calcific aortic stenosis of a trileaflet valve other than age. That is not correct because it has been observed that even in trileaflet valves, they have risk factors they're exposed to the same risk factors that is associated with occurrence of other atherosclerosis, such like diabetes mellitus, dyslipidemia, and etc. That is to say, dyslipidemia and things like diabetes mellitus predisposes to aortic stenosis. So that makes option C not to be correct. No, option B not to be correct. So the only thing left here is C. Calcification of congenitally bicuspid or normal trileaflet valve is the most common cause of aortic stenosis in adults in the United States. Of course, that is correct, at least according to the text. Thank you very much. That's for question 539. The answer is C. Calcification of congenitally bicuspid or normal trileaflet valve is the most common cause of aortic stenosis in adults in the United States. If there are no more contributions, can we move to question number 540, please? Thank you. Thank you very much. Thank you. It's okay. Oh, this foul. We're off the grid. Thank you. A 68-year-old man with chronic aortic regurgitation presents for office evaluation. He describes reduced exertional capacity, recent exertional dyspnea, and occasional orthopnea. His echocardiogram shows severe aortic regurgitation, a left ventricular N systolic diameter of 55 millimeter, and a left ventricular ejection fraction of 55%. Which of the following statements regarding valve replacement for chronic aortic regurgitation is correct? A patient with severe aortic regurgitation who have symptoms of heart failure but normal left ventricular ejection fraction do not require valve replacement surgery. That is not correct. By the time you have symptoms, you need a valve replacement. And left ventricular end systolic diameter greater than 50 millimeter before surgical intervention portends a worse post-operative prognosis than does a smaller ventricular diameter. Yes, of course. This is true from the several studies that have been conducted. Now, C says angiotensin converting enzyme inhibitor. That is not correct. And D says patient with chronic aortic regurgitation who have symptoms of heart failure accompanied by reduced left ventricular ejection fraction should be followed with annual echocardiography. That is false because by the time it gets to less than 55%, we are advised for replacement, for intervention. Thank you very much. So question number 540, the answer is B. An LVN systolic diameter greater than 50 millimeter before surgical intervention portends a worse post-operative prognosis than does a smaller ventricular diameter. Thank you very much. Thank you for the opportunity to answer these questions.
Thank you so much, our class rep, Chief Kuzuki, for helping us to do this. We also thank every other presenter of today, Dr. Alagbe, Dr. Ruki, and Dr. Brown for stepping up to take the concluding part of Braunwald. I am excited to announce that we are done with Braunwald. Braunwald was finished in 20 days, although what we wanted before was that we should finish it in about 15 days. But I guess that we still tried finishing it in 20 days. And that's very good. The curriculum presenter of today couldn't come up, so I'll reach out to him to see what we can do, because if we wait till next week, it might be drawing us back. So if we can take it tomorrow, we'll get back to everyone as concerns that. That said, over to you, Dr. Uzoke.
Yes, let me read one of the charts here.
Yes.
Aside from the traditional risk factors mentioned concerning the causes of atherosclerosis and the aortic stenosis, that lipoprotein A is now a recognized risk factor for aortic calcification and subsequent stenosis. Thank you, Dr. Rukayat. There is no more comments here. Yes, thank you, everybody. Good evening. It is good to know this. May God crown all our efforts with success. Today being, it's not up to 12 yet. On Saturday, we are still having our evening discussion. I don't know whether, okay, and we agree that we are starting with Prof's MCQ. Please let everybody prepare his own. We should finish the Prof's MCQ before the week goes half. The worst case scenario before the week goes out, we should have to finish that Prof's MCQ. Let us buy time for some other things and have time for a few revisions as much as we can. Please, everybody should please go and read your parts. Thank you very much. Please, the person recording, can you please stop recording? Thank you for being able to finish the Braunwald in a relatively record time. Thank you for all the participation, contributions, and our efforts. May God grant us success. Amen.
Amen.
I think I don't know whether I saw Chief
Oyema and Fatima, they've left now.
Okay, what of I saw Quickie sometime. Chief Quickie is still here.
Yes, he has not stopped recording.
Okay. Hello, Chief Quickie. Good evening, sir. Hello, sir. Let me try calling.
What did you say?
Let me try calling him.
Okay. I hope your network will not. No, you're not close to the mango tree.
I think the bandwidth for this one for Chief, good evening, sir. Sorry, we just finished.
Hello. Hello, Adeyanju. How far?
Chief, welcome, sir.
Hello, can you hear me?
Hello,
Chief. Can hear you very well, sir.
Yeah.
Yes.
So sorry. How long were you able to finish Braunwald?
We just did, sir.
Is that?
We just did, sir.
Fantastic! Congratulations. That's a great one.
Mm-hmm.
So Sunday we'll meet by 6 o'clock, which is day after tomorrow, to look at the management of hypertension, guideline-based principles.
You guys go asleep.
And Monday we'll take it over from there. So thank you. Congratulations. A wonderful job.